there. Thank you. Yeah. Right. If everyone can be seated, we can begin. I'll give you one more minute to find your seats. Good morning, Vanakkam, Namaste, Shubho Sakal, Sabah Bakir, and Ayubowan from Colombo, to everyone in the room and everyone joining us on the live stream. Wherever you are watching from, you are very much part of this conversation today. My name is Dilmini Veersinghe, and it is my privilege to be with you today as we launch the 4th edition of the Health and Humanity Summit 2026. And this year, we ask a very deliberate question. What does it mean to envision the future of humanitarianism? Some of you here have been with us since the first edition of this summit. Others are joining for the first time. The journey of the Health and Humanity Summit started in 2023 in New Delhi, and then in 2024 in Colombo. Last year, we had the summit in Kathmandu, Nepal, and this year, we returned to Colombo. Over the years, this conversation has grown from a regional dialogue into genuine cross-border exchange of ideas, bringing together humanitarian workers, policymakers, healthcare professionals, researchers, and most importantly, the people whose lives are at the center of all this work. This year's summit could not come at a more consequential moment. The assumption that have underpinned humanitarian action and global health for decades, that civilians deserve protection, that healthcare should remain accessible even in crisis, that international cooperation is both possible and necessary, all are being renegotiated in real time. Today is about asking together what humanitarian architecture fits for this moment should look like, and having the honesty to build it deliberately rather than simply inheriting what came before us. Before I go any further, I would like to draw your attention to something many of you have already noticed on your way in. On your right-hand side is our storytelling stage, and the sculpture at its heart, Humans Need Humans, is only one part of it. Around it runs an immersive gallery, One Wall, Beyond Borders, introduces you to the MSF's international mobile staff from across South Asia and Central Asia, who have carried humanitarian values into conflict zones, disease outbreaks, refugee crises, and natural disasters around the world. Each portrait tells you who they are and why they chose this work. Encompassing MSF's core value of bearing witness, the other wall, the people we meet, turns the lens around. Patients presented not as beneficiaries, but as individuals with names, families, extraordinary resilience, each sharing in their own words what made the biggest difference when they needed healthcare. At the center of it all stands this transparent sculpture, Humans Need Humans. It begins today, almost empty. Throughout the summit, we request that you pour a small amount of sand, and each color representing different communities that make humanitarian work possible. Healthcare professionals, government, academia, civil society, media, students, private sector, donors, and more. No single color completes it. Only together does the picture become visible. By the time we close this event, what began as an empty sculpture will have become something none of us could have built alone. I'd encourage every one of you to take a few minutes today and walk through the gallery and add your color to our sculpture. And while you're there, please take photographs. We would like for you to share your stories and your experience here today on social media. And please make sure to use the hashtag HHSummit whenever you do, so we know you posted it. And before we welcome the first speaker, we have something to show you. And that's the reason why we are all here today. Now, I'd like to invite to the stage a humanitarian with over 2 decades of lived experiences, our own Executive Director of MSF South Asia, Mr. Parthasarthi Rajendran, to set the stage for our next discussion. Thank you.
Good morning, everyone. Very warm welcome to Colombo and to the Health and Humanity Summit. I'm really happy to see some familiar faces, so many friends, colleagues, partners, thinkers, practitioners, and fellow travelers from the humanitarian and health fraternity gathered here today. Some of you have come across from South Asia, some from beyond the region, and many from here in Sri Lanka. Thank you for making the time and to be part of this conversation. A few months ago, when we were discussing what should be this year's summit theme should focus on, the conversation didn't start with a big strategy or a fancy theme. It started with a question. The question was, can we consider health as a public good in a world where it has been commodified? Over the years, I've seen families run from one place to another, trying to save someone they love. A mother, a father, a child, spouse. They start with a hope. They go with one clinic to another hospital and a private facility because they are told that this is where they get faster care, better test, and the medicine they need. And then the bills begin to literally pour in. Thousands of rupees were spent on consultation fees, diagnostic tests, medicines, transport, food, accommodation. And they lost wages. Families sell jewelry, property. They borrow from relatives. They take loans. They delay other needs. They do everything possible because when someone you love is sick, you don't start making calculation. You just try to save them. And I've seen some of these families arriving late to our facilities in the field, exhausted, almost broken, not only by illness, but by the cost of seeking care. They have already spent everything they had in trying to escape a health crisis. They have fallen into an economic crisis. In trying to keep one person alive, the entire household had been pushed closer to poverty. The point is that the time many people reach free care, they have already paid too much, financially, emotionally, and physically. That's what, when I wonder, shouldn't this make us all to pause? Stop for a moment. When did the healthcare become just a commodity available to those who can afford it? We are not buying a phone, we are not buying a ticket, a service. When people are sick, they are vulnerable. They do not have bargaining power. They cannot wait for the market to become fair. They need care. They need it on time. Hence, the need to health and to be understood as a public good that protects individuals, families, communities, and economies. When people can access quality healthcare without being pushed into poverty, children stay in school, families remain stable, workers remain productive, and communities are stronger. And today, this matters very much in South Asia. In our region, illness rarely comes alone. A family may be caring for someone who is sick, while at the same time facing a flood, extreme heat, displacement, food insecurity, death or loss of a livelihood. And when a health system is already fragile, a crisis can make everything harder. Climate emergencies, disasters, conflict, and other crises take away the very system people depend on to receive care. For families, they are not separate challenges. They are part of the same reality. So when we talk about the future humanitarianism, we are also talking about the future of the health systems. Think, can our people access care before selling anything on their own, all they want? Our public health systems are equipped for emergency protection of these same people? Can we push an equitable idea of health? I think our theme today is envisioning the future humanitarianism. That comes from knowing the future humanitarianism is here and now. It's not something that abstract, but we have seen in our clinics, our country programs, our hospitals, our regions, most importantly in the lives of the people living in the crisis. And we most certainly don't have all the answers. But when I see you all here, I see hope. I know we have already taken a step towards asking those ambitiously right question with commitment and honesty. And we most importantly, South Asia is a region of knowledge, experience, harmony, struggle, and political imagination. A region that has lived through conflict, displacement, epidemics, climate disasters, economic shocks, and deep inequalities. And region is still very strong, having good resilience, health innovation, civil society action, and public health leadership. So I invite you today to think together, to challenge each other, to imagine a humanitarian system that is more honest about power, more rooted in communities, and more representative of the global south, and more courageous in defending access to healthcare and human dignity. You may ask why now? The answer is simple. It is the triggers we witness all around us. The long shadow of conflict, displacement, instability in Afghanistan, where access to healthcare, education, and public life, especially for women and girls, remains deeply constrained. The continued displacement of Rohingya communities in Bangladesh and across the region, reminding us the protection, dignity, access to services that cannot be treated as temporary issues. What about the climate emergencies? They are becoming more frequent and more severe. Floods, cyclones, landslides, heat waves, droughts affecting Pakistan, Bangladesh, Nepal, India, Sri Lanka, and beyond. Not just seasonal disruption, but health, livelihood, humanitarian emergencies. Think about dengue outbreaks closer to us here. Strained health system is what the outcome is. So we see migration, urban vulnerability, shrinking civil space, and distress in institutions, and that's how people experience crisis and help today. And we also see something else. Communities, organizations, women's groups, health workers, public institutions finding ways to respond with even fewer resources. So I invite you to ask, what can South Asia, what can we contribute to the future of humanitarianism? You would have noticed that we have a 3-panel today, very interesting panel. When we designed this today's program, we wanted the panel to reflect these 3 big questions that keep coming back in our discussion. The first question was power and architecture. Who decides? Who counts as a humanitarian priority? Who funds the system? Who governs it? Who is invited to the table? And who is expected to simply implement decisions made elsewhere? This is our first panel on envisioning the humanitarianism and health architecture. This is especially relevant for South Asia. Our region has enormous needs, but also enormous capacities. Countries in global south are financing most of their own healthcare than before. New actors, including the region, many countries, are shaping health, development, and humanitarian cooperation in new ways. But we all know financing alone is not enough. If resources shift, but decision-making power does not, then the system remains unequal. So this panel asks, what would a more representative humanitarian architecture look like? How do we build systems where priorities are shaped by need, by communities, and by shared responsibility, not only by political visibility? The second question was about women, care, and leadership. Think about a time during floods, displacement, outbreaks, we see again and again that women have been at the center of response as doctors, nurses, ASHA workers, community health workers, midwives, caregivers, etc. Women held systems together, yet we fail to highlight their expertise and leadership. This is why our second panel, looking at the future of women's leadership in global health and humanitarianism. This is not only about representation. Although representation matters deeply, it is also about whose knowledge counts. It is about whether people closest to the communities are trusted to shape policy. It is about whether care work is valued, paid, protected, and resourced. And it is about what happens to health systems when women and girls are denied education, mobility, safety, or public voice. For South Asia, this is central to the future of humanitarian healthcare and humanitarian action. The third question will be on access and sovereignty. COVID made one of the most painfully clear. Science can move fast, but access does not move equally. Vaccine, diagnostics, oxygen, medicine, technologies reach different parts of the world at a very different speeds. So our third panel is looking at the healthcare sovereignty and access. For us, sovereignty does not mean isolation. It does not mean every country doing everything alone. It means the capacity to cooperate from a position of a strength. It means regional manufacturing, technology transfer, fairer intellectual property rules, stronger public health systems, and solidarity that is practical. South Asia has a major role to play here. This region has scientific capacity, manufacturing capacity, public health experience, and a long history of South-South solidarity. The question is, how do we use the capacity to ensure people in crisis can access the medicines and the care they need when they need them? At MSF South Asia, we see this summit as a more than an event. We see it as a space for honest dialogue, for disagreement, for learning, and hopefully for new partnerships. MSF is an independent humanitarian organization, but we do not see ourselves as the only voice in this room. The future of humanitarianism will not be built by one organization, one donor, one government, or one sector. It will require governments, civil society, community leaders, health workers, academics, journalists, humanitarian organizations, and people directly affected by the crisis of all shape the conversation. And it will require us to be humble. Because if humanitarianism is to remain relevant, it must listen more carefully. It must share power more seriously. It must recognize local legitimacy. It must protect principled action, and it must be willing to change. Today, I hope we can discuss difficult questions without becoming cynical. I hope we can critique the current system without losing sight of what is possible. I hope we can speak about sovereignty without forgetting solidarity. And I hope we can speak about the future without ignoring the very real suffering that is happening now. I really want to thank the keynote speaker, Professor Dr. T. Sundararaman, for joining us and bringing such a deep experience in health systems, public health, and people-centered movements. I also want to thank all the moderators and panelists of the rest of the day whom have traveled and made time possible extremely in that demanding schedule. Your presence is what will make today rich and meaningful. And I thank everyone, government officials who really took time to come here and participate, and civil society, academia, media, humanitarian organization, and health institutions for being part of this conversation. So warm welcome once again to the Health and Humanities Summit of 2026 edition. Thank you and look forward to this conversation today. Thank you.
Thank you, Parthasarathy Rajendran, for welcoming us and framing so clearly what's at stake today. Before we talk about systems and architecture, it's worth remembering that humanitarian actions begins when one person chooses to help another. To introduce our first session, I invite another humanitarian on stage who has taken her expertise from years on the field and now ensures that humanitarians across South and Central Asia are matched with contexts that need them the most. Please welcome our Director of HR, Simi Bashir.
Thank you, Dilmini, and thank you, Sarathi, for setting the day ablaze with those powerful thoughts. Like Dilmini mentioned, I'm the Director of Human Resources. Naturally, I'm going to pitch the start of this day with human beings, not human resources, not the counts on our data sheets, but with the good human beings, with their heart in the right place, who go to the field, and like someone mentioned, before we complain about failing systems, politics, bureaucracy, the inadequacy of environments to meet to humanitarian needs, reflecting upon that good bunch of people, the good bunch of ideas which make things possible. The most urgent and persistent question we as humanitarians always reflect upon is always, what can we do for someone else? If we don't ask that question, your ideas will not be put across the table at the right place. So we in MSF South Asia, we recruit people from more than 14 countries of Asia. MSF globally recruits much more. We have more than 29 recruitment offices in the world. Here specifically, talking about an international staff pool which we have, it comprises of more than 500 medical professionals, non-medicals, paramedicals, who go to almost 300 to 400 missions we have in the field. So missions span from different medical verticals. It does not always mean that we are working in the thick of war in Gaza, in Ukraine. It also means we reach to those pockets of the world where there is vulnerability, there is lack of medical care, there is lack of access. The people we send out work in extreme low resource settings like most of us are familiar with. This clearly asks us consistently to contain the outrage we have ourselves personally when we see humanitarianism at an advanced stage of decay. It constantly asks us to step up above all that, make it a bit personal on our commitment to serve humanity in a very human way. With that brief introduction, I have the heavy job of introducing some stellar personalities from our international staff pool who have been with us for the last many years, going to different contexts, performing there, coming back. Do not kill their spirit of working with us again and continue with their humanitarian spirit. I see some of you really laughing, but it's the reality. You know, when we conceived this session, and the person who conceived this session of storytelling and reflecting upon voices from the field, he could not join, but I must make a mention. Deepak is the person who gave birth to this idea. I asked him what is expected out of me to pitch this session to the audience, and he said, you have to throw some light on humans need humans, the starting point of every humanitarian activity. I hope I can do some justice to that. Amongst us are seated 3 international staff from the South Asia International Staff Pool. We have Dr. Roshni. So it all looks like a surprise. We are not introducing them on the podium because we really want this to be a spotlighted session. This is the first session. We also want our audience to turn your neck here and there, be a little active and fully energetic during this session. Dr. Roshni is a gynecologist in our pool. She has done some great missions, for instance, in Malawi, where she treated patients with cervical cancer. She has also worked in providing maternal health care in some of the hardest contexts like Afghanistan, where you can imagine what is it that women have to go through. We are also an organization which respects women in leadership. We are very conscious of the fact that the context from where we are deploying our women are also ripe in a lot of structural bottlenecks which we ourselves as women need to cross to provide this much needed healthcare to women. So Roshni is going to walk us through some of her experiences and hardships in these contexts. After Roshni, we have Imtiaz, who is not a medic, but he has grown through logistics, supply, operationality in different dossiers which humanitarian work needs, and is currently managing a very senior and heavy portfolio in Ethiopia, where he is in a position to shape or carve the humanitarian space through policies. Then we also have a very effervescent doctor, very sober and undramatic leadership, Dr. Karan Kamble, who has been with us also for the last 10 to 11 years and will walk us through some of their experiences. Let us begin. I would request all of you to turn your attention to your right, to our storytelling podium. And I think the spotlight is going to begin now.
Good morning, everyone. And thank you very much, Simi, for that beautiful introduction. So, I want to begin with a woman I had met in the initial days in my mission in Afghanistan. Let's call her Sakina. The name is fictional, the person is not. So she was working as a security guard in Lashkargah in Bose Maternity Hospital where we were posted. What struck me about Sakina was that she once wanted to pursue a career in medicine. And she was short of completing the course by 1 year when circumstances changed and she had to discontinue her education. And now, here she was, working as a security guard in a maternity hospital, but unable to pursue the profession that she had once hoped for. Her story stayed with me because it made me think about healthcare in a way I had not considered before. We often think about healthcare in terms of doctors, midwives, nurses. But what about all the factors that determines who gets to become a healthcare worker, who gets access to healthcare, and more importantly, who gets left out of it? It's when I also started realizing that healthcare does not necessarily always begin inside of a hospital. And before I go further, I think I should also be giving a bit of a context of how I ended up with MSF. So I have always been interested in humanitarian work, but in the midst of my training, my work, and just getting on with life, it was always in the back of my mind. Until a few years ago, when I read a book, The Pearl That Broke Its Shell. It was written by an Afghan-American author, Nadia Hashmi. And it talks about Afghan women, their circumstances, and their restrictions that has shaped their lives. I remember very clearly feeling deeply affected by this book, and at the same time, also feeling a little helpless. I also remember sitting, a kind of discomfort because sitting cozy in my room, reading a book about women whose lives were completely different from mine. And I knew at that time that I needed to do something than just sitting and reading about these stories. I wanted to be of use in some way. Cut to a few months later, I applied for MSF. And then a few years later, I was on my mission to Afghanistan. Now, when I was leaving to Afghanistan, I had a simple idea of what humanitarian healthcare was. You go to a place where people need help, and you try to help. But I very soon realized it was not that simple, because I was entering into a country where there is already an existing healthcare system with its own people, its own history, its own strengths, its own weaknesses, and its very complicated relationship with power and access. I'm an obstetrician and gynecologist working in India, and I have most of the years worked in hospitals which have a very straightforward approach to medicine. A patient comes to you, you examine her, you treat her, you operate on her, and then she goes home. But my two missions, one in Malawi, working in cervical cancer, and the other in Afghanistan, working in maternal and reproductive healthcare, disrupted that very neat understanding of what healthcare meant to me. Because suddenly, I was beginning to see what happens to women before they reach the hospital, and also what happens to women that keeps them from reaching a hospital. So in Afghanistan, I came across many women in the months I worked there, and their stories made me realize that healthcare is not just about having access to hospitals, doctors, and medicines. There was Fatima, who was short of 1 semester from completing her medical studies. There was Gulmohar, who had finished her medical studies but unable to sit for her exam before her university closed. And then there was Bibi, who decided to take the path of midwifery as she was beginning to realize that becoming a doctor in her country was becoming more uncertain. Now, these women did not lack in ambition or ability. They were all stopped by something far larger than themselves. Because we talk about health workforce in terms of numbers, how many hospitals, how many doctors, how many medicines. But what happens when a system does not allow you to become that very doctor, the very nurse, the very midwife? What happens when the people excluded from the system are predominantly women, especially in a setting where female patients require women healthcare workers in order to access care? So it's no longer a workforce problem. It's more like a healthcare access problem. It's a question of rights, and ultimately, it's a question of who gets to participate in building the health system that is ultimately meant to serve their needs. This summit asks us to talk about or think about the future of women's leadership in global health. Afghanistan made that question more concrete for me. You cannot build a resilient healthcare system while simultaneously removing the women who help sustain them. It also made me realize something else. Sometimes access to healthcare is not taken away because there is no hospital. Sometimes it is taken away because the choices that is meant to build the health system does not consider the people that is meant to serve. And then is when I understood that humanitarian healthcare cannot be inseparable from politics, power, and governance. It all comes down to these questions. Who decides? Who's allowed in the room? Whose knowledge counts? And most importantly, who gets left out when these decisions are made? Now, humanitarian crisis does not always happen in the context of a conflict. Sometimes it's just a daily wage earner, a woman, deciding if she can afford to spend a day in getting screened for her cervical cancer. My experience in Malawi showed me a different side of healthcare access problem. It was an early morning It was raining in Malawi during the monsoons when we set out to go on our mobile cervical cancer screening program. And this was the truck. Can't go back. Sorry. This was the truck that we use, which has an inbuilt gynec consultation room. So we decided to drive into the village of Chiradzulu, into a busy marketplace, and this is where we were going to find the women to get screened. Our team had already been talking to the community, and one thing became obvious very quickly. For many of these women, coming for screening was not just a medical decision, it was an economic one. Most of them are daily wage earners, and already when you're stretched thin, trying to provide for your family, spending a day focusing on your own health is not a luxury you have. So while, many times we find ourselves asking, why did this patient come so late? Instead, I think we should frame it more as, what would it have cost her to even just come to the hospital? I remember watching our team work. We had William, one of our nurses, who was explaining to these women in a very simple way as to what cervical cancer is. We had Ida going out into the community, talking to the women and convincing them to come for the screening. And slowly, women began to come in. Some were curious, some were embarrassed, some were clearly uncertain as to what it is they are even doing here. And eventually, one by one, they were all getting screened. Watching our team work that day was very humbling because I realized that screening itself is the easy part. What is more difficult is trying to convince the women, trying to get the trust of the community, giving them the awareness as to what we are trying to do, and also getting these women to trust you enough to speak about the most private parts and their healthcare issues. So this experience changed how I understood access to healthcare. We tend to think about access more like a problem of geography. Is there a hospital nearby? But I came to realize that access means something more. Can I afford to come? Can I leave my children for the day? Do I trust the system? Will I be treated with dignity? Do I even understand why I need to be here? This is where my two missions began to talk to each other in my head, because in Afghanistan, I watched women being pushed out of the healthcare system, and in Malawi, I saw women struggling to get into the healthcare system. Completely different circumstances, same underlying question. What stands between a person and the care they need? Sometimes it's border, sometimes it's poverty, sometimes it's gender, sometimes it's the absence of a healthcare worker, more specifically a female healthcare worker, and sometimes it's a decision made in a room far away from the person whose life will be affected by it. As doctors, we are trained to look at a person in front of us, and rightly so. But humanitarian work asks us to look wider. What happened to this patient before she came to us? Her livelihood, her family, her education, her access to information, her ability to travel, to make decisions. I don't think humanitarian healthcare can be separated from the systems around it, such as financing, policy, workforce, community. But at the end of it all, I feel what sits at the center of this work is actually much simpler. It's the people. Humanitarian healthcare is not a story of doctors arriving somewhere and saving people. It is the story of the people in those countries, the driver who gets you there, the nurse who knows the community well, the translator who makes a conversation possible, and the woman who convinces another woman to come in, the local health worker who continues to show up long after the international team has packed up and gone. MSF has a word for this: bearing witness. I think that's one of the most powerful things we do in our work. You see, you listen, you learn. You don't just arrive, deliver a service, and leave. And sometimes you carry a responsibility to tell people what you have seen, not because you have the solutions, but because the people whose lives you have encountered deserve not to become invisible. I came back home from these missions to my familiar world of hospitals, operating rooms, clinics, but I found I could not look at a patient the same way again. She's not just a person sitting in front of me, she's just the visible end of a largely, almost invisible system. So when we talk about healthcare sovereignty, female leadership, humanitarian architecture, financial aid and access, all of this can seem like big words, and they are. But we can always bring them back to one person, one woman, one community, one decision, because ultimately, every health system is experienced by a single human being, and every decision of the health system reaches somebody's body, somebody's family, and somebody's home. I still think about Sakina, the security guard, who was standing outside of the other side of the glass in the maternity hospital. I think about the women in Malawi who have to decide whether they can afford to lose a day's wages to get screened for a cancer that they do not yet have and do not yet feel. And I still think about the people I have worked with who make it seem very easy in such places. And these experiences left me with a fairly simple understanding of humanitarian work. We cannot solve every crisis. We cannot remove every barrier. We cannot always fix the system overnight. But we can choose to see the barrier. We can choose to listen to the person on the other side. And we can choose to ask who's missing from the room where the decisions are being made. Because maybe the future of humanitarian healthcare is not about building bigger institutions, but perhaps it is more about building human institutions. So if I could leave you with one question, it would be this. When someone is unable to access the healthcare they need, what is standing between them and that care? And when you know the answer to this question, what are you willing to do about it? Because behind every policy is a person, behind every statistic is a story, and behind every health system are human beings. And at the end of every humanitarian response is something very fundamental. It's the people. Thank you.
No. Let me check the mic. Now it's okay, good, good. Thank you, Dr. Roshni, for your telling about your journey in Malawi and Afghanistan. I will take you a bit different way because I'm from operations side, not from the medical person. I like to ask you and the audience if anybody know which country is the youngest country in the world. Anyone know? Youngest country in the world? South Sudan. Yes, I heard South Sudan. Anybody ever flew in this kind of a plane? An MSF plane. We have this, we called it the Grand Caravan. So I'm going to talk about this plane, a bit of journey and my story around this plane. In 2009, I was posted in Lokichokio, which is a small base town close to Kenyan South Sudan border. And Lokichokio used to be called as a lifeline for South Sudan mission when there was a war going on between South and North. So when I arrived there as a base manager or capital logistician, I was supposed to manage the supply, service provisions, and all the support to our projects in South Sudan. But then I got to know that I also need to handle our flight management. Means this flight with the 2 pilots will be under me, and I need to arrange their movement every week, every day. So we used to have this plane, and we also have other plane as well, private service chartered company, which we also flew. So I sent one plane to one of our project in Nasir. Nasir, if ever you work in South Sudan, you will see that Nasir is a town next to a Nile River. Nasir do not have any airport or anything. It's like a airstrip. In one side of airstrip, you have a Nile River. In another side of airstrip, you have minefield. So if pilot make mistake, both way you die, either in through the minefield or in the Nile River. So when I sent this flight, when this flight was coming back, and one of our project coordinator, he also came back on that flight, and he came directly to me. And he asked me, Imtiaz, which airlines you sent to pick me up? I said, no, this is ALS. We usually use that. Only thing is that it has 1 pilot, because this plane can be run by 1 pilot. So I said, okay, I was a bit worried what's gone wrong. Maybe they did some mistake on takeoff or landing. But he says, no, no. When we were coming back, flying back, the back door, you see the back door, it's got open in the sky when they are in the sky already. It's only him and pilot. They are both sitting on the cockpit. I said, okay, very serious. Then he says, no, this is not the very serious. The serious is when pilot said, if I can fly, and he's going to go backside to close the door. Then it became serious. I said, oh, okay, so what you did? Then I said, no, no, I asked the pilot to fly the plane. So he went backside to close the door. So this is how these things happen in our many missions. But the thing is that what we learn from these things, that back then, I'm talking about 2008 and 9, we were learning, MSF was still learning of many things. And after that, of course, we brought new regulations that there need to be minimum 2 pilots, and radio communication, any other policies, all the policies were developed by that. And also this flight was really necessary to continue, because this was only lifeline for all our referral patients. The patient which we cannot treat, which need an operation, we need to fly them with this plane to nearby operation theater. So this was a key options, only one options to fly them out. Thank you. And now I will say, okay, just a bit how I joined MSF and how I became one of the MSF person. It was early stage of my career. I was working for an internet company and looking for new job, like all other, many of us looking for new job after the graduation and after some times. I'm talking about 2003-4. Internet online job profile was not there, so we all need to look on the newspaper where any advertise comes or not. So I saw advertise. I just applied left and right. Suddenly I received a phone call. A foreigner, I'm from Bangladesh, so a foreigner called, you applied for MSF Holland, we like to call you for an interview. I said, did I apply? MSF Holland, which organization this is? Then he says, yes, it's still in this newspaper, you can go and find it out, and I will call you back if you are still interested. So of course I go back and I saw the advertisement. It was a technical logistic officer. My background is engineering, so that's why I applied. So anyway, I got the job. But I took this job because it's like any other 8-to-5 job, not considering is it a humanitarian organization, what it do. For me, it was 8-to-5 job to grow my career. How this job changed me, when the first time it changed my concept was the humanitarian organization do. In my first visit in my own country, I was traveling, I was based in Dhaka in the capital, and then I was traveling to Chittagong Hill districts. We have 3 hill districts, we are traveling there, and we have a project in Khagrachuri, which has a border with Myanmar as well. So we arrived there. It was we first taken it to flight, then 4 or 5 hours journey. We arrived Khagrachuri, we need to stay overnight. Then next day, we need to travel again, another 2.5 hours, very bad road. Then a boat, MSF, own boat, first time, local boat. In boat, with the canal, I think we travel another 1.5 hours. Then we reach a remote village, very close to the border. And I was surprised to see that all the villagers, children, the farmers, the women, they're all waiting for MSF to come because it was an MSF mobile clinic. And this is the only clinic, once a week, they receive for healthcare. Around that, any walking distance, the closest walking distance health center will be 1 day walk. So they are fully, the MSF is the only way they can get their treatment. They provide us food, they cook for us, they provide us land, they provide us a hut to allow our medical people to do their work, and while we were discussing with the other leaders. So it was really heart-touching for me that foreign organizations know what is need of our country. And as a Bangladeshi, my government, my people, we were not aware about the situation our people are facing. So that's completely changed me, how I look humanitarian organization, and it's built up that I need to work more for this organization and grow more closer to my people, and of course the people of other countries later on as well. So that's how I started my MSF journey, and also this is how I became more humanitarian, I will say, more human, I say. Sorry, who has the, sorry, yes. Thank you. So this was the ALS plane I was talking about, not MSF plane. Now I take you guys in Ethiopia in 2015. So I was working in Ethiopia mission that time, and we went and opened a new project in Shimelba, which is close to Eritrean border of Ethiopia. It's called a Tigray region and Eritrean border. The Shimelba, we start a mental health clinic and normal clinic, outpatient clinic there. This camp has a specific identity. Eritrean refugees who fled to Shimelba refugee camp were young youth and children, with roughly 41 to 44% of the population being under the age of 18. A notable portion of these children were unaccompanied and separated minors. Minors, many of them are boys and girls, fled Eritrea independently at young as 15 years old. Even some of them was 13 years old even. Now, I like to ask audience here, if you are parents, or think about if you have brothers, sisters who have that year, like 12, 13, 15. So you are in your country, you are letting your children or your brother and sister to go to another country. You never know you will see them again in your life. You don't know they will survive in your journey or not, in their journey or not. They may not. You may not see them in your entire life. Just think about when you think about your children or your young brother and sister, and think how that those parents how the mental trauma and the children's were going on. But still the parents agree to let them go because there is no other option for them. In 2026, I go back Ethiopia again, and I found that that camp is completely vanished, no more there, because of civil war which happened in 2020, 2021. The camp was completely destroyed. So even we don't know, the population moved to other places and we don't know where they are right now. Maybe those children, what was happened to them, I don't think so anybody can tell now. And yes, so just want to show you as well. So this was our camp, and the life we think about our children, and life the children are having there. This is a photo of that Shimelba camp, a young child carrying waters for their survival. Next, I like to talk about Dr. Udni. He was our president for MSF from South Asia, from India, actually. And during 2010 to 2013, he was a charismatic leader, I will say, that he influenced me a lot. I met with him several times, and I like this quote very much, so that's why I put here for all of you, that medical humanitarianism is an act of solidarity, not charity. It's one human being recognize the dignity of another and refusing to look away. Now, currently, also I'm working in Ethiopia, as you all heard about it. What is the situation in Ethiopia right now, just to inform you at? The 2015, I was working in other camps as well, like camps for South Sudan refugees. And if we talk about Rohingya refugees in Bangladesh, where I work as well in 2021, its situation is different now. That time, there was many organizations providing many kind of a support, like education support, food support, medical support we are providing, child protections. There was many kind of services. But if you go now, most of those services, most of NGOs, they're leaving. They need to close their programs. They need to close their offices as well due to the fund crisis right now they are going on. The whole humanitarian world is going on. And this is very key concern because nobody wants to live in those situations. This is a photo from Rohingya camp. So who wants to live here? No one. But things are going bad to worse. So we all need to think as a human how we can do what we can do ourselves to improve the situations of all these people. Now, I will not take much time. I'm almost at the end. So at the end, I would just like to mention that we live in a world of growing distress and division. There is a humanitarian crisis all around, whether it's war, natural disasters, or climate change or new diseases. Yet, the stethoscopes remind us it's a simple truth. Beneath the politics, every human heart beats the same way. We cannot heal wounds with medicine alone. We heal from the presence. We heal from the dignity. So I'm asking you today, when you look at any crisis, do you see a statistics or do you see yourself? We are only human through the humanity of others. We cannot heal from a distance. We need to reach further. We need to give more. Because ultimately, humans need humans. Thank you.
Thank you, Imtiaz. Good morning. Good morning. Before I say anything about humanitarianism, I want to ask you to do something. Think of a time when you helped a complete stranger. And it doesn't have to be dramatic. It can be as simple as helping someone who had fallen down, helping someone with directions, sitting with someone who was having a terrible day, or just simply listening to someone. Now ask yourself, why did you do it? In that particular moment, did that person's problem become your problem too? Because I think that is where humanitarianism begins. It doesn't begin with an organization. It doesn't begin with a logo. It doesn't begin with a policy. It doesn't even begin with medicine. It begins when one person looks at another human being and decides that you matter. My name is Karan. I'm a medical doctor from India, and I've worked with MSF for the last 11 years across multiple contexts and humanitarian settings. I've worked in fragile health systems during outbreaks, emergencies, and in places where resources that I had imagined when I graduated as a doctor that I would have were never there. Most recently, I have worked on climate sensitive diseases in Cambodia and Philippines. And the challenges that the ever changing context when it comes to climate is having an impact on the population who are already vulnerable. But when I look back at all the years that I've worked with MSF, it's not the policies or the protocols or the algorithms that I remember. What I remember are people. And the question that I keep coming back to is, what does it mean to be a humanitarian? When I finished medical school, I didn't have a grand philosophy about humanitarianism. I was a young medical doctor. I wanted to practice medicine, and I knew something else about myself. I wanted to help people. So I joined MSF. At the time, I thought that I knew what I was signing up for. I wasn't. Because humanitarian medicine has a way of taking everything that you think you know about medicine and put it under pressure. You don't always have the investigation that you want. You don't always have the medication that you want. You don't always have enough staff. You don't even know if your intervention is going to work. And sometimes you have to confront the most uncomfortable reality for any doctor. You cannot save everyone. And I learned that in a clinic in More, Manipur, India. It's at the border of India and Myanmar. A woman in her late 70s had come to us. She had been previously diagnosed and treated for tuberculosis multiple times, and she was still coughing, losing weight, having fever. And then we did an investigation, the basic investigation for tuberculosis. And we found out that there was no TB in her sputum, there was no tuberculosis bacteria in her sputum. Her chest X-ray had cannonball opacities. And I was like, something is not fitting. So we sent her for additional investigations, and we found out that she never had TB. What she had was cancer, which had spread to her lungs. So now I knew what was wrong, but it doesn't necessarily mean that I could save her. There wasn't much that we could offer her in terms of curative treatment, but we could still provide care. So for as long as I was working in that clinic and she came to us, we provided her with cough medications, we gave nutritional support, we tried to make it easy for her. Because we knew that she was not going to live much longer, but we still knew that she deserved care. That was the first of many times that humanitarian medicine has taught me that sometimes we will not be able to save everybody. Sometimes there will be nothing left to cure, but there is always something left to do. And then there was a 19-year-old man in Agok, South Sudan. He had tetanus, severe spasms, convulsing, high-grade fever. We had no syringe pumps. We did not have a ventilator. And the parents wanted to take him home because they believed that he's going to die, so he might as well die at home with family. And I remember thinking, and I told them, like, please give us a chance. I think we can save him. So we improvised. We formulated a treatment regimen which included antibiotics, muscle relaxants, and we worked with what we had. 23 days later, that young man walked home. So one patient died, one patient survived, and I remember them both because they taught me something about responsibility. Medicine is not a promise that you can control the outcome. Medicine is a commitment that you will do everything and anything that is reasonably possible for the person in front of you. Sometimes that looks like fighting for recovery, but sometimes it looks like relieving suffering. But in both times, it means refusing to give up too early. And then in Greece, on an island in Samos, I learned something completely different. I was working on the island of Samos providing emergency medical care for new arrivals who were coming to the island. And one day, there were armed and masked men who were waiting for them when they were arriving. Like the migrant population, when they would arrive, there were already some people who were wearing masks and had weapons with them to just round them up. But the migrants who had arrived, they weren't going towards these masked people. They were hiding in the mountains. They were scared. They were afraid. And I remember thinking that this doesn't look like a medical problem at all. So these people, they were actually afraid of what would happen to them if the masked men would have found them. So when the MSF medical team arrived to this landing site, I heard the masked men shout to the other masked men saying that, let's go, we can't do it anymore. The MSF people are here, let's just leave them. And then they left. We hadn't treated anyone, we hadn't vaccinated anyone, we hadn't diagnosed anyone, we hadn't even touched another person. But we protected them. And I was left with this thought, like, what just happened? Because until that moment, I had thought that humanitarian medicine is about practice. You see, like you go, you see, you diagnose, you treat, you protect people by doing provision of care. But sometimes humanitarian presence itself can be protective. Sometimes you don't have to save a life by touching a patient. Sometimes you save a life by making it possible for the other person to come out of hiding. That day, I understood the power of bearing witness, and it stayed with me. And this is where humanitarian work becomes complicated. Because helping people isn't as simple as having good intentions. I've worked in places where my own concepts and ideas about health, humanity, dignity, rights, they've been challenged. No, they don't perfectly fit neatly within the society around me. For example, in Kenya, Mombasa, I was advocating for the rights of gender and sexual minorities in an extremely religious, conservative context. So when I went to the person who was sitting in the ministry, and I asked them, like, why would they not allow this person to come to the clinic? And then they gave me reasons of them being, transgendered person. And our conversation changed from having a medical discussion to having a religious discussion, because before I went to that meeting, I asked my nurse, like, what did she know about this person? And this person would go to church every Sunday, sit on the front row. So I knew that I need to find a common link between the two of us to negotiate for access. And this was a purely non-medical negotiation for medical access. So that was one of the first times humanitarian practice changed my understanding of what it means to be a doctor. Because here the matter was of principles. So, because principles matter, but so does the context. You cannot simply arrive somewhere and assume that because you have the right answer, everyone will immediately see it. And often, you need relationships before you can bring about change. And that was a very uncomfortable lesson for me. But some of the most important lessons are: over time, my role changed. Over time, my role changed. I stopped being the doctor at the bedside, but I started managing teams, medical strategies, and policy making. And eventually, I realized something. My patient wasn't always a person anymore. Sometimes my patient was a team. Sometimes it was a healthcare system. Sometimes it was a strategy. And that changed the way I looked at my responsibility. A doctor needs a nurse. A medical team needs logistics. A project needs people who understand the context. The international staff require local staff and local colleagues. And a leader needs people who will agree to disagree with them. Some of the moments I'm proudest of, they will never appear in a report. And they are not even moments when I have personally solved a problem. They are moments when I've watched somebody else grow. A young nurse becoming confident at a procedure. A medical doctor taking on responsibility they once thought was beyond them. A pharmacist finding their voice. A deputy medical coordinator becoming a leader during critical incident. Because eventually you realize humanitarian work isn't only about what we do to people, it is also about what we help people become. And now, the challenges are changing again. Climate-sensitive diseases are forcing us to think differently about humanitarian medicine. The environments in which people live are changing. Disease patterns are changing. Health systems that are already fragile are being required to absorb these new pressures, and the problems are becoming increasingly complex. But I've discovered something about myself over the years. I like complexity. The harder the medical problem, the more curious I feel. The more uncertain the situation, the more I want to understand it. I still want to know more, learn more, do more, give more. I want more endurance, more perseverance, more kindness. And I think I understand that this is also a part why I stay with MSF. Because there have been many moments when I've wanted to leave, and I won't lie about it. Almost every mission has had a moment or a point where I've thought I've had enough. And yet I kept going back. Not because every mission was easy, and certainly not because humanitarian medicine is always rewarding, but because I knew that what we were doing mattered, and I think that distinction matters. I don't believe that I make the difference. I don't think humanitarians work that way. The difference belongs to a much larger network of human beings. It belongs to the doctors, the nurses, the families, the patients, the communities. It belongs to you and to me. No one person does humanitarian medicine. We do it all together. The woman in Manipur needed someone who would care for her when medicine could no longer cure her. The man in South Sudan needed someone to say that I will do it. The people hiding in the mountains on Samos, they needed someone to arrive and bear witness. My teams have needed people to train them, challenge them, and sometimes simply listen to them. And I have needed them all. My patients have taught me, my colleagues have challenged me. The communities I have worked in have changed me. I entered humanitarian medicine wanting autonomy. I discovered responsibility. I entered wanting to help people. I discovered how much people are going to help me to become a better doctor and hopefully a better human being. So if you ask me today, why did you choose to become a humanitarian? My answer is different from the one that I would have given you 11 years ago. I started because I wanted to practice medicine. I stayed because I saw that what we do matters, and I continue to stay because I still want to become someone better equipped to be useful. And I want to be brave enough to show up and to show up again. Not because I think I'm extraordinary, but because I have learned that ordinary human beings can do extraordinary things when they refuse to look away. So I want to leave you with just one question. The next time you encounter someone who has been left behind by the system, someone who cannot access healthcare, someone whose voice is being not heard, someone whose suffering has become invisible, what will you do? You don't have to save the world. You don't even have to have the right answers. Maybe you can treat, maybe you can speak to them, maybe you can teach, maybe you can simply stay. But whatever you do not underestimate the power of being there. Because humanitarian action doesn't begin when an organization arrives. It begins much earlier. It begins when one human being looks at another human being and decides, you matter. And perhaps that is the simplest lesson 10 years of humanitarian practice has taught me. We build systems, we develop technologies, we write protocols, we write algorithms. But none of those things can replace the most fundamental thing that we have, each other. Because when everything else falls away, when the system fails, when resources run out, when medicine can't cure, there's still something we can give. Our presence, our attention, our courage, our humanity. Thank you.
Hello, thank you. Karan, stay, and I will request Roshni and Imtiaz to please come over here. So that was quite a scintillating session where humanitarians spoke from their guts, spoke from their heart. We did not plan an elaborate question and answer session for this one session. We only meant to smooth sail into the day with you. But as powerful as these talks were, I can actually see some curiosity, people slightly jumping off the chairs. And we are not in a position to say no to some of our medical student colleagues. So on that table, you wanted to really ask a question.
Yeah, so hello sirs and madam, hello everyone. I'm Sharaf and we are from the Faculty of Medicine, University of Colombo. So as a first year medical student, I actually had a question directed towards Mr. Imtiaz Wadud. Really inspiring speeches, by the way, sirs and madams. I mean, if there was more time, I would like to ask questions from you as well. But for Mr. Imtiaz, I actually wanted to ask, so I see people, they secure jobs in the private sector for a stable career pathway. So what was it that actually inspired you to stay in the humanitarian sector and keep you committed to it till now for such a long period?
Thank you for that question. Yes, as I mentioned, there was lots of small things happened during the course of my journey with MSF. Like when I see the happiness of the children when they get treated, when I see that happiness of the parents' eyes when their children get treated or their relatives are getting treated, that's also give you inspirations. Yes, of course, you are right that probably if I choose a commercial line, I will get more stable or more money or whatever, but that's not only the way to become happy. So we should find what the things make us happy, and helping people make me more happy, and seeing that doing something, I'm not a doctor, but I do lots of things which support our doctor to do their job, and that's make me more happy and to continue with MSF. Thank you.
Welcome, sir.
We might have time to pick up one more quick question before we wind up. Is there anyone who's brave enough to raise the hands?
No, from MSF.
Yeah.
Thank you very much. My name is Donald. I'm from MSF Southern Africa. And thank you for your stories. If you would change one thing in MSF currently, what is it that you would change from your experience? Thank you.
I mean, there are many things.
So everyone is wondering what to answer because there are many things we would like to change. Yes. And that is how we should be as humanitarians. We always look for change. If there is something which should lead to that change, we know that the humanitarian world is shrinking. The needs are immense, the resources are less. How do we prioritize to make the most valuable impact to wherever we work? How do we not look behind? They all set the same thread. So that is where, look at things you can change to lead to our goals to help humanity. That is what I would say. Not a very specific answer, but we don't necessarily need to be specific being humanitarians. Thank you. And I would really request a loud round of applause for these three who have spared time. Thank you very much. That was the first session, and let me hand over back to the organizers. Thank you.
So moving on to our next agenda item, which is the keynote for this event, we turn from individual stories to the bigger question. Behind all of them, what values should shape global health and who gets to decide? So our keynote speaker has spent decades at the intersection of medicine, public health systems, and health rights, from leading state and national health systems resource centers in India to serving as a global steward of the people's health movement. So please join me in welcoming Professor Dr. T. Sundararaman, Adjunct Faculty, JIPMER International School of Public Health, who will join us in speaking with us on the values that shape and determine global health. Over to you, Professor.
Thank you for the honor of having me here. I begin with my salutations. I begin with my warm and deep appreciation for MSF and all the people who work in it and the marvelous things they do. I have been a witness of MSF through many of my friends over many years. I am always surprised to find people whom I had never thought of it landing up in remote areas in extremely difficult situations and holding out on that. So thank you. It's an honor to be amongst you. And all these words which you spoke just before in the earlier session, many people speak these in conferences. But when you speak it, given your experience, it brings an authenticity to it, it brings an inspiration to it, which should not be lost. I'm going to use this time to sort of reflect upon some of the larger issues. We have the slides? Yeah, okay. I'm just certain larger framing things because we come from different backgrounds, different countries, different systems, different ways of thinking of change, of health system strengthening, of humanitarian aid. And we should see what some basic core values that shape and determine global health on this occasion. I begin with two poems. They say literature can capture the human condition much better than many scientific works on that. So here's from a Palestinian poet, 1994. A man crosses the street in rain, stepping gently, looking 2 times north and south because his son is asleep on his shoulder. No car must splash him. No car drive too near his shadow. This man carries the world's most sensitive cargo, but he's not marked. His ear fills up with breathing. He hears the hum of a boy's dream deep inside him. We are not going to be able to live in this world if we are not willing to do what he is doing with one another. The road will only be wide, the rain will never stop falling. I think this is something that we really need to think about again and again on this. I wonder whether we have the earlier next version with a version marked V1. Can you change this? Take a minute. I was a bit worried that you are going to have a slightly long version of this. There's a version V1 that we had sent on this one. Huh? Yeah. Now, I have it on a pen drive, but I don't know whether that will work. Minor changes, but I thought it would be easier for the flow. All you need to do is just escape this and just go open it. Yeah, okay. This one? Yeah. You put it on the WhatsApp? No, I put it from the pen drive. Oh. Okay. It's just that poetry needs to be written in its format. It can't be converted into prose. Is one of the issues that I have. Very minor thing, but it's still important when you're reflecting. So, I came in at a time when we say the resources of the world are finite. What is infinite is the capacity for carrying. And there is a dream here, a dream of a world that can be. Because eventually human beings are caring. But this is also a world of deep and great injustice. I have this brilliant poem from Bertolt Brecht, which was written long back. I hear that in New York, at the corner of 26th Street and Broadway, a man stands every morning during the winter months and gets beds for the homeless there by appealing to passers-by. It won't change the world. It won't improve relationships amongst men. It will not shorten the age of exploitation. But at least a few men have a bed for the night. For a night the wind is kept from them. The snow meant for them falls on the roadway. That's a vision of humanitarian at an individual level. But Brecht goes on. But please don't put the book down on reading this man. A few people have a bed for the night. For a night the wind is kept from him. The snow meant for them falls on the roadway. But it won't change the world. It won't improve relations among men. It will not shorten the age of exploitation. This balance between the individual humanitarian instinct that at some point is at all in all of us. And the world is shaped by most unequal forces and instruments of power and control, like people highlighted before. This is a balance that we try to secure in our humanitarian work. We deal with health systems. We are in fact in many crises because of injustice. And yet within that injustice, we have to find the meaning, like the man with the boy on his shoulder, trying to make a better world within such thing. It was caused by injustice, but within that, how does humanitarianism proceed on that? It's with this background that we will need to look at the intrinsic values of what healthcare means and global health, and the changing values in state policy and organization of care over the centuries, so that we have some key principles that we can base our future movement on. Now, modern public health had a very sad beginning. It actually begins organizing as a science in the 19th century, late 18th century, much driven by the colonial urge, by the need that you need to protect the barracks of the invading armies, and you need to protect the civil lines from illness. At one point, somebody was telling me they were going to Liverpool, and I was telling them, you know why the London School is there at Liverpool? I mean, Liverpool School of Tropical Medicine was there. It was the hub of slave trading once. And one of the first concerns of public health was actually to keep slaves healthy enough to be sold. So it came from extremely dismal settings, but they've moved quite away from those settings. But this was there in all those countries. And there was also a notion of hegemony, of Western science projected as part of a civilizing mission. So while all this thing was there of it being a civilizing mission, it remained very constrained. But even at that time, there was an alternate set of values much propagated, and one of the names most associated with this is Rudolf Virchow. He is known to many people who work in mainstream biomedical as the father of modern pathology. You still have Virchow's nodes and Virchow's this. But he's also, for many others, and in the textbooks of preventive and social medicine, known as the founder of social medicine. He was also an anthropologist of his time. And he starts with this particular articulation of medicine is a social science and politics is nothing but medicine on a large scale. The diagnosis and treatment of an illness in an individual is seamless with the diagnosis and attending to the problems of the illness of society itself. And medicine as the science of human beings must point out problems. Politicians, the practical anthropologists, must find the means to solve them. And the call of a physician, even in those times, was as he calls it the natural attorneys of the poor, people who stand up for the rights of the poor on that. I'm so happy that in different ways we are in a forum over here where most people will find this resonating with them. I'm used to talking of this in different forums where this is far from their thoughts on this. So in the early organization of healthcare, as different from what individuals will do when faced with a patient, there were certain critical steps. And one of the earliest, the origins of public health, actually starts in late 19th century. One of the sources where it starts, its roots is where you have these trade unions who come together and pool money to call what is called sickness funds. So that if any one of them gets sick, they can draw from the pool and pay for their protection or their family. It's an act of solidarity. It's a pooling of risks. These words that we use so loosely actually arose in a trade union context. And the trade unions became so powerful, and this was this period, 1848 to 1870. Virchow himself was in the barricades along with Engels in the first revolution. He went on to make policy on that. And Bismarck really recognizes that if he is to put this threat, this new form of trade unionism at rest, he needs to actually, the state has to intervene in a powerful way. And therein arose the notions of national health insurance and public health in an active way. There's the sanitarian revolution in UK, but that's a different thing in terms of the organization of healthcare. Now, this is European. In Indian situations, in many developing world, we have indigenous systems which are also great on a system of self-help. People would give what they could, and they would receive the care that could be provided. And one of the major sources of the Charvakas and their story. This was not, the Charvakas were a particularly, if we may say so for their time, an atheist group, a group that was consciously materialist in its overall outlook. And that they did believe in humanity as their central thing, and the whole organization of early medicine was there. There were mainstream Ayurvedic philosophies that did draw on divine substance, but this was major issues. But you look at mission hospitals, and you look at why the Christian missions became very interested. For them, the concept of witnessing was very important. Jesus Christ healing the sick, Jesus Christ washing the lepers' wounds, caring for them. At some point, the act of witnessing before your God and before your fellow man was another motivation. The points I'm trying to say is healthcare at the individual level by the provider moved in a particular direction, whereas you have the healthcare needs of state policy moving in another direction. With the end of colonialism and the great debacle of the world wars came to an end and the crisis comes to an end, a new era dawns, what Eric Hobsbawm calls the golden age of capitalism on that, the golden age, where public health becomes central to nation building across developed and developing nations. And that's the time of the UN declarations, the WHO declaration. The attainment of the highest levels of health is a most important social goal. It was seen as the charge of nations and the role of international agencies to help this. Socialist nations had made this a foundational principle, and challenged by that also by the Keynesian economics and different sets of values, industrialized nations had either adopted the National Health Service model or the Bismarckian health insurance or national health insurance model, which consciously talked of solidarity, health rights, and the welfare state. The only exception in this is the US. Even in the US had substantial degrees of state intervention on this. Developing nations, on the other hand, underwent a different transformation. For them, nation building was equal to decolonization. It was important, therefore, that you have ways of self-security, of self-reliance, of health security, of sovereignty. And even if you were not opting for a socialist country, as in the third world, a strong public sector, not only in healthcare delivery, in pharmaceuticals was also necessary, because you would not able to sustain. Sri Lanka is a great example of the self-reliance, not necessarily in manufacture, but in the organization of access to technologies. Legendary figures like Bibil Senanayake, and person whom I was personally inspired by, Balasubramaniam, out of this tradition. But you also have in healthcare delivery the necessity of this. Again, Sri Lanka is one of the great examples of this particular understanding of nation building, a phase that is still present on that. And international health emerges as a discipline setting priorities, humanitarian need, and external development assistance on this. This was to change very sharply under neoliberalism with the rise of a market fundamentalism and structural adjustment policies. Now the notion of international health gives way to global health, which could be the same thing, but very often comes to mean that the global south is giving problems and there are global institutions wedded in the north which are offering solutions on that. This happens in both developed countries and developing countries. But in developed countries like in the UK, efforts to say privatize the national health services go only so far and no further. There is a pushback which is able to limit it. Whereas in the global south, except for a very few countries, this does not really happen. And therefore, the original values that we had become undermined. So instead of self-sufficiency, you have global supply chains. There's a loss of priority for self-reliance in production. You even start talking of the public sector as inherently inefficient. Before, when you built something like my alma mater, JIPMA, as a medical college institution, you provided the housing for them, you provided the schools for their children, you provided all the necessary infrastructure, but you didn't offer a very high salary. The understanding was, if you need a high salary, go work in the private sector. But if you are in public service, we take care of your basic needs with comfort so that you can dedicate yourself to public service. But now you flip around and say, oh, they get their salaries, they get their housing, so why will they work? Unless there is high profits dividing them, they won't work. Public sector is inefficient because you give regular salaries, keep everybody contractual, keep everybody precarious, keep everybody on tenterhooks, and that's a better system on that. At some point, the whole sense of values that defines what is a functional system itself changes. But neoliberalism itself comes into the crisis with COVID-19, when all this myth about how this will work fails, the global supply chains fail, the private sector is missing in action, intellectual property regimes do not lead to innovation, and there is massive disruption to all life, not just public health. And what you have in this period, it's not totally by chance that you have a huge multiplication of humanitarian crisis. Middle East is in flames. There is Europe. Europe is at war. You have the situation in the Sudan, in Ethiopia, in Congo and Latin America, and you have this whole rise of the American first policies, which the difference in Trumpism as different to earlier phenomena is you don't even drop the pretense that it will be good for you. You're just saying that it may not be good for you, but this is what we require on that. Humanitarian action moves within this situation. It creates greater opportunities, if you may say, for humanitarianism. But humanitarianism is not only about saving in emergencies, and much more, and I think that's the spirit of this conference also, it's not a short-term ad hoc response. One must avoid weakening health systems and instead build them stronger with medium and long-term action. So whereas much of the 20th century we would talk of international aid, humanitarian aid, as responding to war, conflict and droughts and floods, the buzzword now is health systems resilience, where you are actually anticipating with climate change a crisis in perpetuity. And you are saying that we need to be prepared for it because we do have this. And therefore, the larger question is, how do we learn from health action in humanitarian crisis to strengthen health systems for everyday use? If you can manage in those desperate situations, why not now, when a standard medical college hospital may get 500 admissions in a standard night, what you would see in a disaster situation, you would find that only 100 of them can be admitted because there are no beds. How do you learn from humanitarian crisis for the everyday, and how do you prepare the everyday so that they are ready for the crisis? So what are the core principles and values that must inform the design of health systems? So we now come in a history where we have always had this conflict between healthcare and this, and we must really look at this. I would say there are 5 key principles that I would like to leave with you, and I see that I'm talking to an audience who understands it quite well. One is building around solidarity. Okay, and solidarity, you have all used the word, and it's been defined in many ways, all of them correct. A community ethic for support, to being the voice of your community. I was recently through a major one international group was looking at this, and they put together the principles of what is solidarity. Is action that entails standing with and for others. Is a form of identifying with. It's a specific type of relationship between people. And it requires mutuality, it requires trust, it requires inclusiveness. And necessarily, and to what end is something that has developed, it's not part of the earlier thing, challenges power differentials, pursues emancipatory ends and in pursuit of health, equity, and fairness. Because solidarity need not necessarily mean equity. All these countries which were built around the principle of solidarity and the welfare state, like Germany is a classic example, now are seriously resisting the inflow of migrants. They feel we've paid our taxes and built our healthcare systems, and these migrants coming in will be drawing away the resources that were meant for our citizens. Whatever happened to solidarity in such a concept? And therefore, the concept of solidarity cannot be only within a particular group. It needs to go beyond that to those who are migrants, who are actually, many economies of the world are built on migrant labor. Much of the wealth is built on migrant labor, and they have a right. On refugees, on the undocumented, a huge category, the stateless, the organized, unorganized workforce, because they are not organized, they don't merit social security. Actually, the logic is this. And we need to think about practical ways to address this. Another extremely important 21st century, late 21st century, not yet late 21st century, requirement is this whole issue about the way identity is waking up. There's always been the problem of the other. We can give for our citizens, but you must prove your citizenship. We can't give you TB medicines because your Aadhaar number does not link. There is 101 ways in which identity is now used to reinforce the power of the state over the individual. And there is this lovely plaque which I couldn't get the original photo of, which is there in with pastures bust on top of it, where you have this pastures it goes back to the 1890. One doesn't ask of one who suffers, what is your country and what is your religion? One merely says, you suffer. This is enough for me and I shall help you. You belong to me. That line was also there on this. You belong to me on this. This fetish that we have of using ID. You may use ID for practical purpose of giving resources. There are practical ways to manage this. In Thailand, for example, there is one insurance for the government employees and the army. You have another insurance for the organized workers. You have a third insurance for those who don't fall into these two groups. You have a fourth insurance for migrants, which the employers have to take out when they get their migrant permit. You have a fifth insurance for undocumented migrants, where you start by getting them documented, and you have a sixth insurance for stateless people because they've been pushed from the surrounding countries here. They don't have citizenship, but they can't go back to their countries also. You have actually 6 different systems. We don't talk about the last 3 because they account for 2 to 3% of the 2% of the whole Thai system. So that's true. When you talk about it, I talk about 98%. But that 2% is important, because if you allow that 2% can be violated, it will soon extend to 90% of the population. You will accept that inequity will go off on this. And this whole issue is, I think, a fundamental principle. How do you organize care? There are issues of financing, but those issues are they allow things. And finally, this is this whole thing about caring over profits, not caring about profits, caring, healthcare caring. It's not about, sometimes this public or private ownership can be trivialized. It's not about ownership, it is about intent. Whether the provision is for care or whether it is for profit making. I tell my students to differentiate this notion between a use value and an exchange value. What is the terms of production of healthcare? So if a mother is preparing food for her children, she wants them to eat and be healthy. She makes sure that she makes it very tasty, but doesn't put that extra oil in, doesn't put that extra spice in, and she will add the greens and make them eat it even if they don't like it. But if she is running a mess outside for supplementing her income, to make the food tasty, you must make it a little bit more oily and spicy, and you must be able to market it, and you will go for a whole lot of foods, and the healthy foods are not on the dish because there's no market for them. So the terms at which you provide, if it is provided for exchange, if it is manufactured in the context of exchange, will necessarily itself a problem. And therefore the challenge becomes, how do you actually organize the delivery so that it is not driven? It could be driven by markets, but we don't want it to be driven by markets. What would be the other drivers? That becomes, and that's something you learn from humanitarian work. And in humanitarian work, private not-for-profit ownership sometimes works better. I remember this whole thing in a 2001 workshop when I went, and some lady was totally confused. She's saying, how do you say I can use public sector in these situations? Only private sector will work. And I remembered that she was working in an organization like MSF. MSF is private sector. MSF is more public than the public sector because public is an intent, an understanding, a set of values. It is not just a mechanical ownership on this. And this important division can sometimes confuse us because it can be really, the public sector can sometimes be user fee driven, cost recovery driven. It can be at sometimes have private behaviors within it, especially when insurance comes into play. So in some sense, it is the motivation. How exactly do it? And finally, the whole notion of global public goods. In classical political economy, it is refined, limited to goods which are non-rivalrous and non-excludable. Sort of, if it means in Colombo, I have a vector control program, and some more people come in, even if they have not paid their taxes, they will benefit from it. Yeah, and similarly, if they have not paid for it, they'll still benefit. So, those have to be public government provided. But that concept needs to extend to healthcare, all healthcare, because there is uncertainty. If I go to a doctor, do I need a normal delivery or cesarean section? Do I need a thyroid surgery, or is it all right? It will not a problem. All of that should be ring-fenced, should be taken out of any considerations of pecuniary profit on this, should be available irrespective of the, and this is not a problem that strategic purchasing has ever been able to solve, though it can ameliorate a thing. And there is an active, it's not just a negative clause, there is an active obligation to reach everybody. So the real challenge is, it's all right to elucidate these principles. How does one build a system that can deliver on these principles? To people with a neoclassical economic background, I have heard one person say, well, markets are like gravity. How can you say a certain class of products like healthcare is exempt from gravity? It will apply universally. Not quite true. There is a whole branch of economics, heterodox economics now, that can give different reasons for it, which can make sense to people like you who work on a humanitarian basis to understand that what you do is also economics. It's about a thing. And therefore, this is an issue. I've spent a lot of my life on trying to actually make sense of this. And I have a book out. I've kept just 6 copies I could bring over here that you may like to pick up. And maybe you can, the WHO can organize more, or MSF can organize more copies. But this is really about how do you construct such systems? How do you look at healthcare financing? How do you organize care? How do you look at informatics? If you build it around the principles of solidarity, equity, inclusiveness, caring, and eventually the notion of global public goods. That is the challenge of our times, and we need to come up with it, because mainstream economics, mainstream theory has only the market-based approach. I think this in Sri Lanka is a good place to start exploring the alternatives in the long term. Thank you.
If I may ask you to join me on stage, we'll take a... Hello. Oh. There we are. It's already here. So, Professor Sundar, I'm going to start with an opening question because I know we discussed this keynote earlier as well. And I think that, and before we get to the questions from the audience, I think it's fair to say that one of your central propositions based on your presentation and our previous conversations also is that healthcare, when it is left to the market, tends to fail. And it should be treated therefore as a public good that should reach everyone. This is a fairly ideological position to take. In your view, what does it take to move from ideology and principle to policy from a South Asian perspective?
It's interesting because though one associates it with a progressive left ideology, it's also been very core to liberal thought. So the origins of this sort of solidarity trust were made in Germany, are successful in Thailand, they are successful in Costa Rica, and many of them have a very strong Keynesian bias. And you know, Keynesian bias is a very different thing on the welfare state. It's the neoliberal thought that really came in the way. What does it take to move? It takes, I think, the interests of people to find voice in the policy space. It also needs an imagination. Because we have now in 30 years not got real experience, and public systems have been dysfunctional. And we have to solve those problems.
You mentioned several examples in the West. Would you take the public health sort of lens and pursuit in Sri Lanka as an example as well?
You see, Sri Lanka is one of the largest histories, longest histories. It starts, I have the great doyen of the Sri Lankan history over here, Palita, so I hesitate to speak, but it starts way back in 1920s. They were one of the global originators of primary health care as an agenda. They worked on that. And subsequently, in this phase of this transition, they were able to actually build a fairly robust public health systems. So 95% of secondary and tertiary care in Sri Lanka is by public providers. There is no private medical education in any significant way. It's all public medical and nursing education. So these are great strengths. But in a very rapidly changing world, whether they have the ability to transform the governance of this in ways where it can innovate with the times to the changing needs, and that too on a rather narrow fiscal space. That's their challenge. So I wish them well, but I'm worried.
Thank you, Professor Sundar. We'll take a couple of questions from the audience as well. If you raise your hands, there are mic runners stationed around the hall and they will get a mic to you. Can we get a mic over here, please? Yes,
thank you. I'm Anuj, and Sundar, thank you for that illustrating speech, which I have had opportunity of listening many years before too. My question is, because it's a humanitarian summit, what we see is basically even the humanitarian spaces, if you look at the operational system, is bought by corporates. I hope you understand what I'm telling. Those spaces are also bought by corporates, and the agenda is set. Where are we heading to?
So there's in all of these a yin and a yang, there is this and there is that. And while we must have the pessimism of the intellect to understand that these forces are there at work, and you have this whole disaster capitalism. You have these wakes of corporates coming in for reconstruction, getting huge contracts, you have supply chains being managed and outsourced, you have that. You also have the opposite, which is also, especially in the humanitarian strength, then prevailed much better. So in some sense, you do have also a very strong pushback to the public sectors. COVID-19 forced one across many places. There's a reversal, but having said that, many systems have strengthened. Now you can see across Africa, especially Africa, the pandemic treaty negotiation has not been a walkover. There is a systematic resistance to benefit and a demand for benefit sharing. There is a whole development of capacity in these that is happening in the African continent. Not so much organized in Asia, but in this that is happening. Latin America also, but Latin America is facing a setback. So I think while you have pessimism of the intellect, there is also what I call what we well known as the optimism of the will. You know, there is so much space and so much work that is happening, which is able to show change if we are much more alert to what can be done. Thank you.
I'm Professor Surendra Kumar. Thank you so much with that, as usual, and I also listen a lot of your presentation and discussions. In line with that, and now we talk about these humanitarian things, and but this healthcare cost is ever escalating and more kind of, becoming very expensive and things, and also need a lot of capital. So then earlier we showed this state and also you said the solidarity, and one of the thing is a lot of cooperative movements and non-profit community care services. But now this kind of a main problem is getting capital and things. So the global funding, solidarity and building up even regional, there's because changing global geopolitical situation and things, there are a lot of kind of isolated and no kind of networks, except few things are surviving like MSF and things. So what do you think that what is the way forward, and considering the need and also the future, and then with all other new developments, what sort of a way of thinking and what we could embark?
I'm not going to fall into a very simplistic way forward sort of thing. It's a sweep. I only say that there are ways forward. You should have the confidence to explore the ways forward. You should have the search for it. Our knowledge is always limited to our immediate experience. For every major thing, there are positive deviances. I was mentioning, how did Costa Rica manage it? How does Thailand survive? There are different learnings over there. And I think there is two things that are happening. When it comes to the global south, there are progressive governments which come in with providing windows of opportunity before they are still swept away by the larger political global division of power. But these are windows of opportunity that opens up when there are governments that come to power with a particular motivation and trying to do things. That there is a much greater role for an organized civil society that also should be able to make linkage with such progressive governments when the windows of opportunity work out. But the third, and I think a very powerful force that we have not yet leveraged in that form, is what I call the public health community, which is this whole sort of people who are interested in health policy, who talk about it, who are practitioners, who are thinking in policy. Why do I say it's important? Some time to time, a window of opportunity opens up when some government gets swept into power. It happened in Nepal. In some way, Tamil Nadu was a transition we didn't expect. Sri Lanka was a major transition. But when that happens, an imagination of what should be the better way of alternative is not there in the public domain.
So in the public domain, there are all sorts of good ideas doing, but at the background, it is the global health institutions who are prevailing along with the bureaucracy and bringing back the structures that were there previously. This linkage between the senior bureaucracy, who has been, more by habit rather than by any evil intention, and their own way in which they look at global health institutions. This combination, so you see in all these countries, after a lot of bold statements, when they finally come out with projects and proposals, they're doing sort of the thing that was already signed on in a World Bank agreement or something like that, the ability to move. And that's not merely conspiracy. It is a lack of conscious understanding of how alternatives can be built. So at some point, I think, therefore, I look at the way you organize work in these remote settings as an example of learnings that can do, even on HR policy. So when I was working in Chhattisgarh and they said they couldn't find people to work in remote areas, I said, how does MSF do it? And if you look at the salaries, it's not all that higher than what we were willing to pay. So there is learnings that should happen, but first and foremost, it's the optimism and the confidence that change can happen.
Thank you, Professor Sundar. In the interest of time, I'll end the Q&A session there, but we will be exploring these topics in the next panel discussion with Dr. Ravi Ranangelia and Dr. Pandav. We have one more. Okay, we'll take just one more.
Yeah, very short one. How artificial intelligence comes to inform all this effort for solidarity and principles and our practice on an everyday life, managing to reach even the most remote ones?
That's an interesting one. I'm in my bitter mood.
You have inspired me, I must say that. You have inspiring speech, I must say
thank you. In my bitter mood, I would say artificial intelligence is a good complement to natural stupidity. You just check it out. If you test it out on a few things, you ask them to summarize, give an artificial intelligence summary of my speech. It will take out anything new I said and give you all the mundane things I said. It will not take risks. Artificial intelligence fundamentally is not logico-deductive thinking. What it is large language pattern recognition. So it is trained on some material and it can at best reflect on that material. So it can do some problems right that nobody human can do, but it can get some problems wrong that a third-year school child will fail for. So if I have some simple questions, there are examples of mathematics problem that it will fail on because it cannot understand or solve that. That's not the problem. Like that plane example, I'm going to love that example he told about closing the plane. He said the door open was not the problem, the pilot going. That's not the problem with artificial intelligence. Everybody gets things wrong. So if they get something wrong, we'll correct it. But you don't know when it gets wrong. It can even hallucinate. It can write you a paper with the references. You don't know when it gets wrong and when it gets right. And having known it's wrong, you can't go back and fix it easily because the algorithms are not transparent. Which is still all right if you can exercise your difference. If you're a great expert, you can see this doesn't work and you'll ignore it. But if you are using it as a thing, then you don't know. The question comes, who is accountable for the mistake? Suppose I'm a mediocre person using AI, I'm a normal person using AI, not a particularly brilliant person in their agenda, and I do not follow what AI does because my discretion is better and it goes wrong, then am I accountable? Why didn't you follow AI? And if I let my discretion aside and go for AI and it goes wrong, who is then the software? Will you bring down Elon Musk and be able to think? He files indemnity clauses in all of these things so that he will not. So I think down the line, AI may give solutions. But we will need to take it one step at a time, look at it critically, see where it works. There are places where it works. So it's not something like I'm saying be dismissive of it. But this gung-ho celebration that AI is going to solve the problems that we all have, that's slightly over the board. I think that's over the top. I don't think we are there. But let us see if there are good people and they use this to make certain uses of it in a very limited space, I think. And it will grow. It will learn to correct. It will learn there's a future there. But so far.
Thank you, Professor Sundar. I'm glad I allowed that final question. We'll close there, but we will be exploring these themes. And with your permission, I will be using that quote in the future on artificial intelligence and natural stupidity. Can I invite our Executive Director, Mr. Parthasadi Rajendran, to hand over a little token of appreciation to Professor Sundar.
Thank you, Dr. Sundararaman. You have given us a lot to think about, and thank you so much for framing the current architecture and landscape that we are working with very clearly to those in the room. We now move on to the first of our three panel discussions, each built around one of the core themes of today's summit. The humanitarian financing model is, right now, at a pivotal point. Shrinking aid budgets, debt pressures, and geopolitical tension are forcing long overdue conversations about how this system is funded and who governs it. Encouragingly, many countries across the global south now finance more of their health care than ever before. The question ahead is whether decision-making power evolves at the same pace as the growing capacity. To moderate this conversation, please welcome on stage Dr. Ravi Rannan Elia of the Institute of Health Policy in Sri Lanka. Joining him on this panel is Dr. Rajesh Sambajirao Panda, the World Health Organization representative to Sri Lanka, and Professor Imtiaz Hussain of the Independent University of Bangladesh, as well as Dr. Samina Ahmad, Senior Advisor for Asia and Project Coordinator for South Asia at the International Crisis Group. Please welcome.
Okay, thank you. So I'm very delighted to be here to be participating in this event. As you all know, MSH has been doing admirable action across the world, but also in our region in particular, not just in the other countries of South Asia, but as a Sri Lankan, we're very much aware of the role that MSF played in previous years in our own struggles. So what I want to do today is, in our session, talk about how we might re-envision the global architecture for both health and humanitarian action. And I'm very delighted to have here three very distinguished, very experienced colleagues from South Asia, from different countries of South Asia, who bring really very different perspectives, but I think complementary perspectives about these challenges that we face. Now, I want to just say a few words about why we have this particular session. So I was part of one of the committees which was trying to think through what we would be discussing today in the different panel sessions. And I think the one thing that became very clear, and I should mention that this group had people from all across the world, from different parts of MSF and elsewhere. One thing that became very clear was that we needed to think about the changing global context in which we, MSF and others, operate. And the reality is that we're living in a period of very fundamental transition. We're moving from, I think, an international system which was largely, disproportionately, shall we say, shaped, managed by the global north, by countries and institutions and actors in the global north, to one in which I think that dominance can no longer be assumed. And we see that in three different ways. The first, and I think this is often very obvious to those of you who work on the ground, not just MSF, but others like MSF, is the very real decline in international funding that we are seeing, not just for humanitarian assistance, but also for broader health system support. The second change that we're seeing is we're seeing that the sort of global architecture for managing support for health systems, support for humanitarian action is itself under strain, is becoming more fragmented. The institutions are becoming challenged and often disrupted, and we see weakening capacity for collective action. And thirdly, and I think this is very much mixed in with all those things, we see greater demands for voice and role by the global south, and changing, I think, perceptions about what is legitimate. So this is the broader context in which you're operating. Now, underlying all this, I would make one very important point. This reflects a very fundamental change in geopolitics or the geoeconomics, which is a shift in economic weight from the global north to the global south. And I think, to be fair, I would actually say it's one of the positive side effects of globalization. Globalization has accelerated that process in recent years. But that shift is making both people in the north, actors in the north and actors in the south, is forcing us all to rethink how we work in this new environment. And that's really what we're trying to bring out in this session. We want to reflect on what's been happening, what your own experiences are, and try to think about what it is that we can all do, not just governments, not just international agencies, citizens, civil society, CSOs, whatever, to adapt to this new reality. I think for the North, obviously there's questions about appropriate resources, priorities, and legitimacy and partnerships and how to do things. For the South, there's really issues about how we all respond. So I think this changing environment creates many challenges, but it also creates many opportunities. And now I'd just like to turn to our panelists to share initially, they're going to each speak about their own experience and thoughts on this broader issue. And then we'll go and move towards a broader discussion between us. And I think I'll open up at the end to questions and answers from the audience. So can I start first with Dr. Pandav, who is, he's from India, but he's been here in Sri Lanka for quite some time as the WHO representative. And I would mention he's worked quite widely in the region. I think in Nepal previously, I think Timor-Leste and elsewhere, and he brings really a quite wealth of experience in that, in his professional career. And I should also mention, I think you also had a personal interest in mental health as well, which is often an issue that we often have to deal with. So, hand over to you, Dr. Panda.
Thank you. Thank you, Ravi. And we all know that the humanitarian landscape is undergoing one of the most profound transformations in decades. We are witnessing an unprecedented convergence of crises, conflict, climate change, pandemics, economic instability, population displacement, and growing health inequities. At the same time, humanitarian needs are increasing while available resources are under considerable pressure, and some of the speakers in the morning alluded to that. This has prompted what many refer to as humanitarian reset. From my perspective, however, the humanitarian reset should not simply be about doing the same work with fewer resources. It should be about fundamentally rethinking how we organize ourselves, how we finance humanitarian action, and how we all work together to achieve greater impact. And I'll say 5 points. First of all, we need to place countries at the center. The most effective humanitarian response begins with strong national systems. International agencies play an essential role, but our role is to support, strengthen, and complement national leadership, not replace it. Countries understand their own vulnerabilities, social context, and priorities better than anyone else. Humanitarian action therefore needs to reinforce national ownership and build sustainable capacity that remains long after emergencies have passed. This is particularly relevant in South Asia, where countries have demonstrated remarkable experience in responding to disasters. Recently, Sri Lanka in Cyclone Ditwa, in the countries I have worked in, Nepal, where disasters are common, natural disasters and others, disease outbreaks and public health emergencies. Second, humanitarian action and health security can no longer be viewed separately. COVID-19 taught us that preparedness is not an optional investment, it is a necessity. Investment in surveillance systems, laboratories, emergency operations, resilient primary health care, supply chains, and well-trained health workforce simultaneously strengthen routine health services and emergency response capacity. Preparedness offers one of these highest returns on investment because every dollar spent before a crisis reduces both the human and economic costs afterwards. The humanitarian reset should therefore shift our emphasis from responding to crises towards preventing them and building resilience. Third, financing needs to evolve. Traditional humanitarian funding models remain indispensable, but they are increasingly insufficient to meet today's complex challenges. We need financing that is more predictable, more flexible, and more locally accessible. Resources should reach frontline responders faster, reduce transaction costs, and support longer-term resilience rather than short funding cycles focused only on immediate relief. Equally important is investing in local institutions that continue serving communities well beyond the duration of humanitarian projects. Fourth, decision-making should become more inclusive. The humanitarian architecture has made progress in localization, but there is still considerable distance to travel. Communities affected by crisis should not simply be recipients of assistance. They should actively shape priorities, program design, and implementation. Local governments, civil society organizations, academic institutions, youth organizations, and community leaders all bring knowledge that international actors cannot replace. A more equitable humanitarian system is one in which decisions are made as close as possible to the people affected. And fifth, partnerships must become more strategic. No single organization can respond effectively to today's interconnected risks. Government, United Nations agencies, development partners, financial institutions, academia, private sector, and civil society each contribute to the strengths. The future architecture should leverage these complementary strengths rather than create parallel systems. And fifth, finally, equity must remain our guiding principle. Whether during conflict, disasters, or disease outbreaks, the populations most affected are often those who already experience the greatest vulnerabilities. The humanitarian reset must therefore ensure that humanitarian action reaches those furthest behind first, consistent with the Sustainable Development Goals and the commitment to universal health coverage. This is not only a moral imperative, but it is essential for effective public health. Thank you.
Thank you, Dr. Pandav. I'm going to, we'll take questions and for later. I'm going to move now to Professor Imtiaz Hussain, who is based at the International University of Bangladesh, IUB, but has a long career working with UNHCR, and also, I think something he's going to talk about, has worked extensively for many years I guess in the context of the Rohingya crisis in the region, but something which I guess I would say as South Asians we should be more concerned about. I think it's often been left to Bangladesh and those nearer to manage. So over to you.
I would like to wish all of you a good morning. I wish to wish all of you a happy good morning, and really want to thank MSF for this invitation. They've done outstanding work, and I hope today we will be able to help them innovate more ways out of the problems we face. I want to thank all of my colleagues and certainly all of you coming to visit. If you think of, I am quite reminded of one proverb. It was called Clash of Civilization, a phrase made popular by Samuel Huntington. And on the one side, you have humanitarianism. On the other side, let's just put it as geopolitics, defined more like survival for the fittest. I'd like to introduce a third force, and this is an increasingly important force, and I just want to call it a secular force. Now, let me apply it to my own case study, which is the Rohingya camp in Kutupalong in Cox's Bazar, Bangladesh. And since when they came in 2017, the UNHCR estimated that it would need $1.2 billion to look after roughly at that time 760,000 displaced, forcibly displaced Myanmar residents. We don't call them refugees. That has many legal implications that we don't need. And then if we look at today, for example, or 2025, the last year of statistics that we have, last year the UNHCR estimated something like $938 million, not 1.2, 938 million. It appealed for that, and basically this was after in 2025, and in 2017 it received only 70% of the 1.2 billion. In 2025, it received only 38% of just 900 and something million dollars for a lot more people. They were now up to 1.4 million. So it's a huge gap. And what happened? Now, if we look at where they went, it might help us understand something. Let me first mention that from the donor side, all the donors, the top donors, are from 3 major continents. They're either European, North American, and down under, Australia. But there are 2 Asian countries, and South Korea and Japan. And so where are they going? Well, 1.2 to 1.4 million in Bangladesh, 600,000 in Saudi Arabia, up to 400,000 Pakistan, and then we come down 55,000 India, and Indonesia 10,000, and like that. None of these are on that list. And so one future strategy that could be devised is how do we get the South Asians and the southern countries more involved? And if they're going to Saudi Arabia, it's one of the richest countries in many ways from the south. So why is it not more involved? When it is hosting up to 600,000 and giving a greater proportion of passports to incoming people than any of the other recipient countries. So therefore, what is going on, we need to find out. That and something else can be proposed, and that is that the UNHCR by constitution really is a very defensive player. That means it's like a Florence Nightingale, a Mother Teresa kind of, come and we will help you, we will care for you. So basically they're putting greater pressure on the receiving country. And what I'm trying to propose to you, and this might really help, is that why doesn't it go on the offensive? For example, go to the home country and tell them something much more that they can do. I know they have begun this with the Rohingyas, but it needs to be much more, there need to be more sanctions. And how do you get the sanctions from an agency like that? We don't know. These are the big issues that we need to talk about. One final comment I would like to make in that is, we are getting the money from states. If you can look at policy making at many different levels, global level, international level, regional level like the European Union, and then state, and then of course non-government organizations, Main Street individuals, for example. Why don't you come down to that level instead of paying your taxes up to the state and letting the state distribute it according to state policy preferences? Just go to Main Street. So I would like to argue very strongly that MSF and others should go down to Main Street and do something that can bring in the cash directly without going through the state or through donations and all that at the state level. That would be my, and for reasons of time, let me leave it there, but these are some of the possible ways that we can begin to get out of, this is becoming a thorn day by day because we have reached a point of no return. The Rubicon is right there. Something's going to happen either this year or next year. Locals have lost all they were the ones that opened up their arms in August 2017 to welcome them, 750,000. Now they don't want them because they are getting much more per capita humanitarian aid than the locals are getting per capita income. And therefore, there's a huge amount of unrest going on locally. Regionally, South Asia, as I mentioned, hardly doing anything really, given the size of the problem. Lots of them are strapped financially or politically or whatever it is. But we need to somehow maybe ignore that part of the equation and come down to Main Street, go to citizens, and then see what can be mobilized there. Thank you.
Thank you, Professor Imtiaz. May I just make a quick note on that? I mean, I think what you're saying is, obviously we're seeing a reduction in the interest and support from the established players in the global north, but there seems to be, what you're pointing to is a growing deficit in action by those in the South, which includes us, includes society, includes governments, it includes people. And I think that's really something hopefully we can say a bit more about later. So I'll turn now to Dr. Samir Ahmed, who's based in Pakistan. And I think, so you work with the International Crisis Group for many years, and also I think head the South Asian operations. And I also know we discussed previously, you also worked very extensively in one of the countries that often sometimes gets forgotten is part of South Asia, which is Afghanistan as well, which has its own very unusual challenges, shall we say. So let me turn over to you.
What I've learned is more, I think, from the speakers in the earlier sessions about the issues that this summit is about. And I think it said right there, which is healthcare is not delivered by systems alone, it's delivered by people. I work for an organization, the International Crisis Group. Our mandate is the prevention, the containment, and the resolution of deadly conflict. So we cover countries through the world where there has been that impact on people of deadly conflict, or where people and communities are still on the receiving end of conflict, and we're looking for solutions in a very difficult world. The challenges are acute of ways, and I think the keynote speaker said it well, is looking for opportunities, looking for ways of resolving the impact on communities, on people of deadly conflict. And in this context, what we have seen in all the countries that I work on is that humanitarian crises have occurred because of conflict, but humanitarian crises have also exacerbated conflict. So if we're going to look at how is it that there can be collective action and collaboration by the Global South in coming down to the South Asian region itself, I think we need to first recognize the challenges. And the challenges are not that different than they were even 10 years ago, 20 years ago, 30 years ago, which is competition instead of collaboration. So how do you actually deal with that very complex region and the challenges that are there to international or regional cooperation and collaboration? As I said, first of all, let's recognize national interests will determine the policies of governments and states. And I don't think there's anything wrong with it, just so long as those national interests do not work to the detriment of the security of the citizens of the region. Security policies and sensitivities, on the other hand, and we've seen this in the context of the conflict zones of South Asia, do create more difficult challenges for the communities that are most at risk. Because sensitivities can mean preventing access to communities most at risk, or conflict can mean that the state is not in a position to deliver the kinds of services that are needed. Third, and I think this is another grave challenge in some ways that we still have to confront, which is the very uneven health structures in this region that we're talking about. And the lack of resources or the political will to build those resources. And how do you address that? It's not just the same capacity in all of the states that we're talking about in this region, and even in terms of human development. I look at Sri Lanka and the levels of human development there, and I contrast them to the levels of human development in Afghanistan, which I do consider a part of South Asia. And within these countries as well, these are large countries that we're talking about. India and Pakistan, between them, is what, 1/3 of the global population. And very, very uneven structures within these countries. And finally, the challenge of different structures of governance. So decision-making at the national level, at the sub-national level, at the regional level. How do you evolve it in ways that will lead to more effective provision of assistance to the folks who need it most on the ground? And I think may have perhaps a starting point will be a dialogue. And I think it's needed, it's about time that we started that dialogue within this region that has possibly some grave challenges right now and possibly graver challenges unless we do address the needs for humanitarian action, the needs for the delivery of systems, and the need for the reform of systems. So what shape can that dialogue take? And I don't think it's a dialogue that is between just decision makers at the national levels. It's a dialogue that should take place at every level. And I think you referred to that as well, Professor, which is a dialogue between different segments of the South Asian populations that have a part to play, whether it's the public sector, the health sector, the private health sector, the health communities, civil society, and I think that's a huge asset that's ignored in this debate. And then finally, the most neglected in our notions of what should be inclusive decision-making is communities. We do not take their voice into consideration. So how can we, this is a great setting to have this debate where you have health professionals, you have people who deal with governance structures, who deal with decision-making, and who deal with communities on the ground. How do you bring those voices, the voices of communities, to the table, the decision-making table, whether it is at the regional level or at the national level? That I consider possibly the gravest challenge. Thank you.
Thank you, Dr. Samir. Thank you all. I'd like to just now reflect on some of those points that came out. I mean, I think this clearly, what was clear was that there's a need for more action by us, whatever, us in a very general sense, in South Asia or in the global South. I wanted to start with Dr. Pandav. Within the international organizations in which you, I mean, obviously you're, sorry. Yeah, okay. I mean, you've been, I think, many, many years in WHO, I think, as a WHO staffer. What do you see the role of countries in the South, particularly in South Asia, but maybe more generally, changing within WHO? I mean, I would say often, I would say in many countries, particularly like ours, we often treat these international agencies almost as in a supplicant role. We're sort of receivers, which is a very different interaction to, say, the way European countries or the North American countries would interact. So do you see a change happening? But also, is there space, is there a need for our countries to be doing more in terms of working with WHO to build regional solidarity to address these common problems in our region? That's sort of one thing I would ask. And then do you think that within WHO and within, I mean, WHO actually is unusual. It's a bit like ILO. It's basically, it's supposed to be a democratic, one country, one vote organization, as you know. But as you may also know, WHO's funding doesn't quite correspond to that. It's also had this dual funding structure where countries make their contributions, and then there are these voluntary contributions, which I assume buys influence, right, within the organization. And I think WHO is trying to do some reforms to that. So do you think, is enough being done in WHO to change how the organization works with countries to give greater role and space to countries in the South, and essentially governments in the South, to have greater responsibility?
Thank you. Yes, in last year, the WHO Southeast Asia Regional Committee was held in Sri Lanka. And one of the things which the member states decided was to expand this corpus of the Southeast Asia Regional Health Emergency Fund. So this is a fund which is managed by the member states for the immediate use of member states when a disaster occurs. To give you an example, in Nepal, during the Jajarkot 2023 earthquake, where this Southeast Asia Emergency Fund was available to the country within 24 hours to address the issue of restoring cold chains and maternal care. So this is an example where this, and similarly for the cyclone response in Ditwa, by 2nd of December, WHO was able to draw from this Southeast Asia Regional Emergency Fund and provide it immediately. So this is an example of South-South solidarity where the countries have come together and worked through WHO to ensure that immediate resources are available and not wait for the global north to provide that funding. So that's one. In addition to that, there are several mechanisms which member states have done. For example, funding which is triggered, for example, anticipatory funding for floods and others, mechanisms which are there, which are used by these countries to do that. It's not only about finances, it's about making sure that South-South solidarity in terms of sharing the technical expertise. There are WHO collaborating centers in different countries, and they offer this technical support for enhancing the capacity for this. So again, I give this example of the Jajarkot earthquake of 2023 in Nepal, where a particular province, and because of the preparedness work which I had done through WHO and WHO collaborating centers, but also with other member states within the region, they were able to respond promptly because of the emergency trainings which they had, the ambulance drivers which had the training, or also using the local capacity, meaning you don't have to wait for people from outside to come. The local capacity for quickly establishing electricity to the birthing center was done. And this was possible through enhanced, continued capacity building support and the various trainings and simulation exercises, but also the health emergency operations centers at the central level, provincial level working, expanding. So that's the role WHO is playing and now is expanding through various means. Thank you.
So just a quick follow-up. Is WHO, you mentioned several examples of regional member states making greater contributions at the regional level, so I guess regional solidarity. Is there more that these countries should be doing, and should WHO also be a bit more proactive in essentially deepening that kind of action?
So countries within the Southeast Asia region, bilaterally, of course, they are doing more. I mean, you saw that in the recent cyclone Ditwa, where India provided a lot of support. So that's more of bilateral support. Whether all countries need to work through WHO, that's not necessary. As I said, it's a partnership among government, United Nations agencies and other partners, but the ultimate objective is it should reach the people faster. I mean, that's what is crucial. That help should reach faster. And as I said initially, the people who are most vulnerable are the most affected by this population. In Sri Lanka, there are several, for example, elderly, estate population in other areas, in Nepal also, far-flung areas. How fast we can reach, and that depends on, as I said, WHO working closely with member state, but also the countries within the South helping each other because they understand the context more than people from the North. And as the funding from the north reduces, it's important that we band together and there is a lot of enough expertise within the region to be able to do so.
Yeah, I mean, in fact, in Sri Lanka with the cyclone, I think India was already here and was in a position to offer assistance in a very significant way. And I think the fact that it was here, it had some knowledge on the ground, really, I think, was a beneficial aspect. Let me just move on. President, you mentioned that we need, WHO obviously, because the nature of WHO has to work with member states, which means government, so that's just the nature of the organization. But I think what you raised is the issue of more that needs to be done by, I think, civil society, by people, by communities in the region. And I wonder, particularly the Rohingya, it seems to me there wasn't that much action really or solidarity outside Bangladesh. I mean, yes, you mentioned Pakistan took some people and whatever, but I think it was still very much a bit further away in the minds of people, not something they felt necessary that they could involve themselves in. So do you think that there needs to be more action at that social level, but what kinds of action would you like to see?
Bangladesh has, I think, Bangladesh has the largest NGO in BRAC, and that is doing immense work just about in every continent you can think about. So at that level, we are very well equipped to do so. For diplomatic reasons, government cannot just downsize international organizations. They have representatives coming, going, and doing so many other projects. So they cannot downsize the WHO or the UNHCR just like that. They will stay there simply because the states are not paying attention to them. And I don't mean Bangladesh, I mean many of the Western countries do not pay that much attention. Yes, the United States is paying up to 50% of the aid the Rohingyas are getting. Half of that comes from the United States. It doesn't mean that we go and tell the United States to downsize, but we need to encourage more. One example I can give you involves the MSF. They were among the first to establish hospitals, little hospitals in those camps, and those camps were just about the most congested spots on earth in a country that is itself one of the most congested in the world. And therefore, when you have 1.2 million people crammed up in a couple of square miles of territory, how do you prevent, for example, COVID from spreading? And luckily, they managed that very nicely. Very nicely. The numbers that came out of the people affected completely lower than the countries, lower proportionately than in many other countries of the world. So there is something happening, and MSF was among the first to create clinics 2020, March 25, I think it was, when they closed the camps because of the COVID outbreak. It was going to stay closed for almost 2 years. And we saw then that both NGOs like MSF, as well as an international organization, UNHCR, really playing a huge role. So I think it is very much possible. We need to encourage it. And Bangladesh is very lenient in allowing NGOs and Main Street people. For example, the July revolution we had 2 years ago, that was done from Main Street. No political party could do what the students did, protesting to get more jobs. So therefore, I think we can speak a lot louder on that front, but we're not edging far. We need to do much more. One option could be the Rohingyas have lots of organizations that have come across in the diaspora. They have diasporas in many countries, so they have created diasporas, but these diasporas are mostly lobbying in parliaments. So it's a very top-down approach when it should be bottom-up. For example, except for the ARNC in the Kutub Palong camp, no other organization, diasporic organizations, have sent any money or anything. All they're doing is lobbying. So therefore, they're just lobbying at the top end and hardly reaching the bottom level at all. And that, I think, is something that could be mobilized. How do you get them to change that focus through civil groups from other countries? And in that way, maybe we might be able to get a little bit more involved.
So let me just pick up on one of your points. I mean, you mentioned with the Rohingya that 50% of the assistance was coming from the United States, which is actually on the other side of the planet, right?
Yes.
So, of course, it's a very rich and wealthy nation. But should there be more action by the countries in the region as well, do you think?
Well, yes.
I mean, you said yes, not to displace the United States, but is there a need for, obviously there's a need for more action because you mentioned the deficit at the beginning in terms of funding.
I think there has to be, but I think you also need to keep one thing in mind, that what you're doing now when you mention United States, you're basically knocking on geopolitical doors, the way you were asking the question. My USA reference was through the humanitarian angle. And the geopolitical thing is that the United States would like to have a Bay of Bengal kind of naval position somewhere. And therefore what the China-Myanmar economic corridor is what expelled the Rohingyas. They have been kicked out several times by the Bamars in Myanmar since 1785. The name Cox's Bazar is named after the British captain who was in charge of that hamlet, which didn't have a name, but he was so young and did a very splendid job. The locals called that hamlet Cox's Bazar after him. And therefore, I think at the societal level, there's a lot of interflows that can go on. But what I'm trying to say is that eviction of the Rohingyas was for creating a seaport for China from Kunming all the way on the Bay of Bengal. And this is what I think India and the United States wants to stop. So geopolitics does come in a big way. And that's why the reluctance of many South Asians and the South from getting too involved.
Okay. That's an interesting point, which I think connects with something that you also mentioned, right? That in this world in which we see these transitions, we're moving from a world where the national interest is important, right? I mean, that's something that's fundamental. It's part of the way the world operates, where we're changing from a world in which the national interests of some countries is more important to a world where the national interests of more other countries becomes also relevant. But that doesn't necessarily mean that it's a better world, right? I mean, as I think Professor Nitesh was just suggesting, there are complexities even in the global south about the national interests of countries in the south. So it's, in a sense, it's a replication of the, shall we say, the previous problem. But do you see that? Do you see any opportunities or chances for improvement, even though national interests will still remain important when we have national interests now for more countries being placed on the table?
I think we should be very careful about these binaries. We had a very good presentation earlier on, I think, which set the stage for this event and for this topic on how we saw humanitarian action and the humanitarian structure emerging out of both the North and the South. Those values that we talk about, the core values, are not limited to the North or the South. They are universal values. The same way, I think, if we talk about geopolitical competition, and we don't recognize the fact that the global south, the countries, the dominant countries of the global south are players in that geopolitical competition, active players, not passive recipients. We do have a problem on our hands. When we're talking about healthcare in particular, and then saying international institutions can't play a role, well, member states are actors, active actors in these international multilateral forums. And in fact, in some ways, we tend to forget that the competition that we have at the regional level between states or their role in that geopolitics is given another at the multilateral level, in fact, a forum in which they can actually conduct a fairly civilized dialogue on their mutual interests. So when we say for this region in particular, where the opportunities, I think that South Asians with their competing interests, whether they're national interests or geopolitical interests, can actually work fairly well within multilateral institutions because they can put the nationalism aside, which very often is also rhetoric and aimed at national populations, and look at interests that transcend borders.
But just to follow up on that, I guess for that kind of collective collaboration, you need an architecture, right? And if I just go back to WHO, we see our South Asian countries, some are in one region, others are in a different region. Recently, the World Bank has split South Asia. They've shifted Pakistan to a different region because there are all sorts of problems about collaboration. And as you know, SAARC is not, I think everyone knows, is not a very active organization for various reasons. So do we need to sort of reinvigorate these existing institutions? Do we need, how do we address this problem? Because I think South Asia does have a particular problem about regional collaboration, even for problems of mutual interest, right? This is not Southeast Asia, this is not Europe.
You're talking about setting up South Asian institutions. Now that's the biggest challenge. That's the biggest challenge for this region. Unlike Southeast Asia, unlike the Middle East, unlike Africa, where you actually have effective regional institutions, South Asia, I think we need to look at it differently. When talking about setting up institutional or an institutional structure, we should talk about a multi-layered structure. And that, in some ways, I think is the way we can bypass these conflicting national interests or competitions or conflict. Because let's be very clear about it. This region is beset with conflict. Is there a possibility to set up institutions, parallel institutions, not necessarily competing with the state, but actually contributing to the state, but also create a regional solidarity? I don't think that's a difficult proposition at all. And I think civil society is the first and the most promising regional level dialogue that can take place in South Asia. And it is to some extent already taking place. But can we find ways of enriching that dialogue and providing it the support it needs through other solidarities? Professional organizations, whether they are in the health sector, whether they are the healthcare professionals, in the private sector or in the public sector, there's a common need and a common understanding of what needs to be done at the regional level. I don't think there's a resistance, but the beginnings will have to be a regional dialogue.
So greater dialogue and, I guess, building partnerships. Do you want to comment?
In the beginning, you mentioned about WHO, meaning the SS contribution will be limited and mostly donor contribution is more. So, but now, as WHO is a member state organizations, they have decided now to strengthen WHO in terms of the assessed contribution, and they have committed that by 2029, 50% of WHO's contribution will be from member states' assessed contribution. That means countries are showing solidarity and to support WHO, and that's why one of these mechanisms of CRF, where WHO will be more strengthened and not influenced by just donor money. So that's progress made by the member states.
It's in a sense one of the positive changes of this transition. Yeah,
Can I just chip in a little bit on the regional? As far as the Rohingyas are concerned, ASEAN has really done nothing, not even taken in the Rohingyas. And except for Malaysia under Prime Minister Anwar, and Malaysia was the president for last year, and under him, he knocked on ASEAN doors very ferociously because he was also a good friend of the chief advisor of Bangladesh, Mohammed Yunus. So they were good friends and they met and they talked about the Rohingyas, but ASEAN didn't move one budge. So I think ASEAN, we need to go slow on that.
I guess that's more a comment on how ASEAN relates to the rest of the world, but I guess within ASEAN, maybe it's an effective institution for regional collaboration. Do you want to add anything? Or?
That's exactly, unfortunately, the world we live in is a world where migrants are not welcomed, refugees are not welcomed. And it's not necessarily just geopolitics. It is xenophobia and nationalism is the environment that we have to confront, not just in the global south, not just in the global north, but I think within our own societies, to recognize that this is an evil that we do have to confront.
Yes, I think it's often easy to criticize others, but we'd often forget that maybe the problems also start closer to home. I'm going to take the opportunity as I believe we have some time for questions and answers. About how much time do we have? 15. Okay. So do you want to comment? Or you want to say something, or do you want to add something? Or I saw your hand up. So.
I think the point was.
Okay. No. Then do you want to say it?
Well, I think the most interesting way that you can get out of this whole thing is that, by the way, the United States is paying 50% of the Rohingya. It is not coming through UNHCR or anything like that. It is coming bilaterally in that form. And I think we really need to get the locals involved, which means the Myanmar groups. We need to really mobilize them and take over. And so if agencies like MSF can go and mobilize them, talk to them and share plans, it is quite likely we might break some barriers there. And South Asia is so divided and so congested, Bangladesh is, to accept any more. And therefore, we just cannot go any farther. And so I think the civil society would be the only way, because every other domain that you look at, whether it is international organizations, that would be very much more politically driven. How many countries pay attention to the United Nations, for example? And so these are some of the concerns that favor NGO, Main Street kind of interaction.
Yeah, in fact, I might just reflect on Sri Lanka, which was brought up in the previous, by the keynote speaker, about Sri Lanka's achievements. And Sri Lanka's achievements isn't necessarily, I would say, because the state was inherently good or did the good things. It was because the state responded to people. It was the people, the civil society, the ordinary people of Sri Lanka who molded that state because they had the opportunity to do those good things. I think it's not that the state is inherently good in that sense. So it all ultimately comes back to people, right? Even if we're talking about state action, even within WHO, it ultimately comes back to how people within societies influence the articulation of national interest at the higher level. So I want to just maybe just open up. Is there a system for, I'm looking at the organizers, for getting questions. I guess you can just raise your hands and we'll figure out how to, yeah, if I can see with the spotlight going in my face. So okay, is there somebody there?
Yes, thank
okay.
you.
If you can maybe just briefly just introduce your name and then
yes,
give
I'm
us your question.
Sakuntala Kadirgama from the Law and Society Trust. Thank you very much for a very interesting panel. All three panelists use the word civil society quite frequently. You have a lot of expectations of what civil society can do. With the exception of Bangladesh, really civil society is also under siege in many of the countries in South Asia. Both in India and in Sri Lanka too. We have a lot of legislation that is being contemplated to really control, stifle civil society, stifle their funding, their works, etc. So I think it's really important that governments in the region recognize that they are formed from the society. There is a symbiotic relationship between them, and they should stop seeing us as the enemy or the other, because there's so much we can do. So right now we are challenging this legislation. I think the same problem happens in India. And you can see that Bangladesh has had a great advantage by recognizing the role of BRAC and even Mr. Yunus's own position coming from civil society. So if we are to find that alternative that our keynote speaker spoke about, that thinking has to come from outside the state, and we should be seen as partners in this. So I am really excited by this conference, and I hope we have the opportunity to explore that further. Thank you.
Thank you. Did anyone want to comment to that? Maybe Professor Imtiaz.
To ditto that, I think what needs to be done is that we need to take the state out of the equation. And so if one NGO deals with another NGO directly, and that way go and mobilize the public, have a session like you are having right now, or have some other university level interaction. And that interaction probably spreads out a vehicle, a window that was not opened before. So unless that is tried out, one will never know, one will never be able to break the state presence in everything. Some states I know cannot do that because they're too involved in geopolitics, too deep in geopolitics. But in other states, I think, you need to begin, and I think the South is filled with many states that are brand new relative to the Western countries. So therefore, national interest will always be at the top. But then if you look across Africa, the continent where the 21st century humanitarian crisis will probably unfold in a much bigger way than we're seeing it now. If you look at Africa, many of the tribes that are rebelling are basically against the state. So this thing is not just a local phenomenon, the Rohingyas against the Bamars. It is happening everywhere. And without fueling that protest, go and channel that energy into some other ways of humanitarian ways, mobilizing them to tell them they probably don't know as much about the afflicted persons as we do today here. Does a Main Street citizen know about all of these? No. Can we take it out to them and discuss it with them? I think the window is open, and I think there is a promise that should not be overdone.
Sure. Thank you. Any other
comments? I can't see.
Hi, my name is Nur Hayati, and my question is for Professor Imtiaz himself. I myself am a Rohingya woman, and I'm one of the co-founders and directors of Human Health of Rohingya, my Funder Collaborative Network. So our work is very largely involved in Rohingya advocacy and rebuilding the Rohingya community. I like that you brought up the concept of, like ASEAN governments, and because even though 50% of the funding comes from the US, when we interact with the US State Department, they also agree, and their rationale is becoming that, Rohingyas are in ASEAN, and so that ASEAN should be taking care of this matter. So from activist perspective, how do we push these ASEAN governments, or even collaborate with NGOs and CSOs within the ASEAN region to put pressure on their governments to cut economic ties with the junta? Because we're slowly recognizing that a lot of oil and gas companies, especially from Thailand, or PTT in Thailand, or Petronas in Malaysia, are actually contributing to the civil war in Myanmar and the Rohingya genocide by supplying oil and fuel, right? So what do you think we should, how should we push for them to cut those ties and, let them know that, we have to work for the Rohingya issue within ASEAN?
Your comment and the sentiments behind them are very much cherished. I think it is something that must be articulated, but I think at the same time, given my thesis of pulling the state out, we should also explore non-state outlets. States, yes, only to disentangle themselves from alliances they might have made or policy interests they might have, alliances abroad and whatever else, but go to Main Street and get the people mobilized and tell them something about what they have not heard from the state before, that this is what we were, this is how. I don't think that is being done sufficiently. I think that can be propped up, the volume can be raised quite a bit on that front. So I would say that yes, knock on state doors only to put this public pressure upon them, but the heavy armor should be on Main Street with other people opening. For example, go to university by university visits. An event like this, by visiting universities, you might be mobilizing more people than they will get from the headline news or on their mobile or newspaper headlines or anything like that. And that way they might get more personally involved. You can leave a number, name or something, and they might be able to come back and contact you. Might not be everyone that you're talking to, but even a 1% kind of positive response is coming out of nowhere into your treasury pool or whatever else you need to function with. So I think, let me just go back to the Main Street. I think the answers, even governments can be brought down there on Main Street. Populism, for example, we've heard a lot about populism, is coming from the same instinct as this geopolitics, survival of the fittest. And we need to kind of move away from that sentiment. We need to show the kind of a Florence Nightingale mindset, heart, instead of the mind calculating all the time. We need to show that heart, the Mother Teresa, that kind of a heart, more than we are seeing anywhere. that's why I would say Main Street is the place to go. It's going to be a long innings. State is tough to defeat in any country of the world. But it's a tough one. But if BRAC can do it, Grameen Bank, microfinance could do it, and really they're the two dynamics that pull Bangladesh out of the basket case that it was in the 1970s. And therefore, I think the long-term dividends are obviously there. It needs a policymaker who's not looking for short-term, quickie kind of outcome.
Any more questions, or I'll make a comment? Any?
Thank you, Sir Professor Imtiaz Hussain and Dr. Samin Ahmed as well. So, sir, I'm Akif and I'm from Bangladesh and I work with MSF, by the way. So my question to both Professor Imtiaz and Dr. Samin Ahmed is that currently the Rakhine State has 17 cities, towns. 14 of them are now controlled by Arakan Army, while for the 3 of the remaining cities, the extreme war is now continuing between the Myanmar junta and the Arakan Army. And at the same time, we are hearing about the narratives of repatriation from the Bangladesh side and Malaysia as well. And very recently, Myanmar also announced that at least 300,000 Rohingya refugees were verified, and if the situation is okay, then they will repatriate. But the question is that these people actually emerged from the Rakhine State. They have been living there for years. So now, amid this situation, Bangladesh is also involved with this type of narrative with Myanmar authorities and also regionally with other countries as well. So if the situation is that the war is continuing, the people who have fled from is under war, and there is no conducive situations for the repatriations. So, and in fact, Bangladesh is involved with discussion with Myanmar authority only, while the place is now under control by the Arakan Army. So amid all of this situation, what Bangladesh government should do for the durable solutions and for the repatriation narrative as well?
Which one?
First things first, I think you mentioned they've been living there for years. This particular eviction has been 10 years now. And so if they're within the camp, they're not called refugees for the simple reason because that's a step towards citizenship. They're called officially forcibly displaced Myanmar residents. And therefore, the ones that are registered are all there. And now, through China, some repatriation was made, especially to Mongdao. And if you noted that, the Rohingyas are truly reluctant to go back. And those that braved it out after 10 years of living in a small tent, those that went quickly came back because they were persecuted there or they feared persecution. So they quickly came back. So if the 300,000 that they are announcing, that is a state level figure. It is not from the camps. And believe me, in the camps, to find 300,000 to go when they couldn't even find 30,000 to go to Mongdao, I am bewildered to think of how the state is basically changing the ball game out on the playground. That somewhere something doesn't fit. And again, that personal Main Street communication, camp to camp, would really help. And I think those camps, the Rohingya camps, They have their own organizations. They don't have funds to donate or anything. They're doing the Florence Nightingale kind of work. If they can be mobilized into shifting another direction and mobilizing the people instead of just healthcare or maternity care or something like that, it might help.
Thank you. Bring this to a close. Let me just, I'll sort of bring this to a close. Maybe I'll just offer one reflection. I was just listening to all our panelists. I think this issue and some of the questions from the audience about what can we do? Now, why can't we get this government or that government to act in a different way? And while that, I think that's commendable, I think we probably need to be a bit realistic, right? I mean, I think the point you made was, yes, there might be greater weight going to the countries in the South, global South, but countries in the global South also have their national self-interests, and that will also dictate how they act. And they're subject to the same influences as the countries in the global North in the way they think about their own national self-interest. And I think I would just recall that the one other example where sometimes civil society has to take the lead. And that's something I think MSF was historically been very concerned about, which is the situation in Gaza. And if you think about the situation in Gaza, it's awful. It's absolutely, I would say, a stain on humanity, what's happened in the past few years. But what we also see is that most governments have done nothing, including our own governments in South Asia. And if you see any hope for change for the people in Gaza, for the people of Palestine, I think it's going to happen because of changes at the public level, particularly in the United States and in Europe, and that's what's going to eventually drive change, because that will eventually, hopefully, manifest in changes in policy at the state level. So states are not going to change their policies overnight. The way they define their self-interest is constrained by other things, but ultimately it requires change at the popular and the public level to drive that state level change. So that's where I would just end to end this session.
Thank you, Dr. Ravi, for conducting this panel, and thank you to all our panelists. In the interest of time, we would like to draw it to a close. Can I please get Parthasarathi Rajendran to provide some felicitations to our panelists? Thank you, everyone. There's been a small change of plans. The second spotlight session will be right after lunch. So right now we can break for lunch. We will be back here in 45 minutes sharp. But while you are moving around the room, please feel free to interact with our art installation. Check it out and also provide your contribution to it. We will see you back here at 1:45 sharp. Thank you. Lunch will be at Queen's Court. Thank you so much. Hi, everyone. Can I please urge you to take your seat, please? I hope everyone's feeling energized after their lunch because we have another spotlight speaker available online right now. If we can get started soon, that'd be great. For the second half of today's program, we have a special speaker speaking all the way from Bangladesh. She is the Humanitarian Affairs Lead for MSF Bangladesh, who will share her story, My Journey as a Refugee and Humanitarian Worker. Without further ado, Showkat Ara.
Hello, Showkat Ara. Waking up early in the morning, praying Salah, helping my mother, learning the Holy Quran at the madrasa, running to a school to study with my friends, and having dinner together with every day with my sibling, my mother, and my father, who was a school teacher. Although life was simple and not always easy, I enjoy being a student and knew that education will give me opportunities to dream. I wanted to continue my education, complete my studies, and build a better future for myself and my families. But I didn't know that one day I would have to leave my home, my school, and the future I had imagined for myself. Assalamu alaikum and good afternoon, everyone. So I am Showkat Ara. I am a Rohingya girl. I'm originally from Butidong Township in Myanmar. I serve in Doctor Without Borders, a humanitarian affairs liaison under the advocacy department in Palukali project in Bangladesh. And today, I want to share my journey, my purpose, my life, and my dreams with you. In 2017 Exodus, everything changed for us. I left Myanmar with my family. Since then, we have been living in Camp 8W in Bangladesh, at the world's largest refugee camp. And when I arrived, I didn't just lose my home. I lost my classroom. Education has stopped. Suddenly, surviving became more important than studying. I had no access to a school or learning centers. I was still young, but had responsibilities. My family needed support. So I made a decision that many young people never have to make. I chose work instead of school. At one point, UNICEF pushed me to teach at a learning center in our block because I was considered one of the educated girls in the community. But I refused because I had not even completed my matriculations. And till that, I was still at an age when I should be studying by myself. After that, I started looking for work to support my family. In 2018, I got the opportunity to work with MSF. I worked with different departments in different roles, such as women health promoter, case-based care, and female health promoter in sexual gender-based violence department. So through my works, I became involved in supporting women, girls, and my community. I learned about health, women's rights, community engagement, and humanitarian work. Through my work, I listened to community concerns, raise awareness, support people to access services, and help bring their voices and experiences forward. Then, in 2024, 3 years away from education, I finally received an opportunity through the Refugee Higher Education Access Program to continue my study. I had to balance my studies with my work and my family responsibilities, but I did not want to lose the opportunity. I had waited for so long. I worked hard, completed my studies, and graduated in the 2026. And later, another door opened for me. I received a scholarship to pursue a bachelor degree in Philippines, majoring in English. For me, this opportunity means much more than getting a degree. It represents how far I have come and gives me the chance to develop the knowledge and a skill I needed to contribute more effectively to my community. As a Rohingya girls with rare opportunities consisting of multiple challenges and barriers, this is one of my greatest achievement in my life. You know, when I look back, I feel that my journey in Bangladesh has been a journey of rebuilding myself. I arrived with interrupted education and many responsibilities, but I did not give up on my dream of learning. What I carried with me was my determination, my experience, and the hope of creating a better future, not only for myself, but also for my family and for my community. For me, education is a second chance that I never want to waste. Today, I work as a humanitarian worker, standing alongside my Rohingya community, particularly women, young people, and families. has strongly influenced why I chose this path, because I have experienced displacement and the challenges faced by my community. I understand that humanitarian work is not only about providing services, it is also about listening, respecting people's dignity, and making sure that affected communities have a voice in decisions that concern their lives. In the future, I hope to become a leader, create opportunities for Rohingya women, girls, and young people to participate, speak for themselves, and take leadership roles. To me, humanitarianism means standing with people, not only helping them in difficult moments, but believing in their potential and supporting them to build a better future. My journey has taught me that even when opportunities are limited, hope and determination can open a new path. I want my future to be part of that path for others. My message and appeal to all audience, please don't let behind our Rohingya community a forgotten crisis. Even after 9 years, I'm still a Rohingya girl from Budidown Township. We did not leave our homeland because we wanted to. We left because we had no choice. We came here not to live forever. We want to go back home, Myanmar, with our human rights, with dignity and safety to life, a free life in my homeland. Until then, please remember us, stand with us, and never let our hope disappear. Thank you. Assalamu alaikum.
We have a lot to think about, and I believe you have set the stage very well for our next discussion. So the next panel is called Envisioning the Future of Women Leadership in Global Health and Humanitarianism. Before we begin, I would like to share an experience that a fellow MSFer experienced back in June. How many of you here left now are female? Please raise hands. How many of you thought about what you were going to wear today? Please raise your hand. Did any of you believe that you will get into trouble because of what you are wearing today? Did anyone? Raise your hands. Not, all of you are beautiful and no one is going to get in trouble. But unfortunately, that is not the reality for the women living in Afghanistan. They are constantly being surveilled for their dress code. And this was unfortunately the reality for a female healthcare worker in Afghanistan that works with MSF. Back in June, she was detained for her dress code, for not complying with the local dress code, and denied from serving her role in the hospital. I don't understand how this can be a reality in this day and age, but unfortunately it is. And this is why the next panel is a crucial one, where we would like to discuss the role women play in healthcare and humanitarian systems, because overwhelmingly, female labor, doctors, nurses, community healthcare workers, and caregivers are female. It is one of these sector's greatest strengths, yet women remain underrepresented in its leadership, and their work is often framed as service-based or a sacrifice rather than skilled and political labor that it actually is. Moderating this panel, I would like to invite on stage Nishita Sharma, the Director of Communications for MSF South Asia. Joining her is Claudio Miglietti, the country representative for MSF Afghanistan, Nurhayati Ali of the Rohingya Mayafanor Collaborative Network, and Nabila Iqbal of the Sisterhood Initiative.
Good afternoon, everyone. Having a lunch post-session is always the most exciting part of the day. I just want to get a sense of how many people are here in the room right now. Do I have anyone here? I can't hear anybody. Do we have people here in the room? That's great. Firstly, I would like to thank Showkat Ara, who was on screen with us just now. She said that hope and determination go a long way. I think that really inspired me. For us to be able, we wish we could bring her here in person, but of course she belongs to the Rohingya community, and for her traveling is just not a possibility, but we're very proud that she was able to join us online and share her story. From Kabul to Cox's Bazar, Colombo to Patna, Karachi to Kathmandu, from South Asia to South America, for centuries, across generations, women have shouldered the burden of care responsibilities. Whether single, married, with or without children, women are the ones cooking, cleaning, caring for loved ones, and holding communities together. This work sustains our families and our societies, yet most of it remains unpaid, unseen, and undervalued. Healthcare and humanitarian systems across the world are sustained by the labor of women, from hospitals and refugee camps to households and communities. Women perform most of the caregiving work that enables societies to function during both crisis and stability. Yet, despite their central role in sustaining systems of care and survival, women remain structurally underrepresented in leadership, governance, and decision-making spaces. Women carry the operational and economic weight of health and humanitarian systems and hold the least formal power to decide how those systems are run. The journey of women as leaders rarely travels from front lines to boardrooms. And in this panel today, we examine the future of every woman as a leader whose potential is lost because health systems did not give her a seat at the table. I have three panelists with me today who are all incredibly inspiring people, and we are very privileged that they're on the panel with us today. Nabila is an activist in women's and minority rights in Sri Lanka, where she's had engagements that were recognized by Amnesty International and the UN Youth Envoy as young human rights defender in the face of the pandemic. We have Noor Hayat on the panel as well, who is a Rohingya community organizer dedicated to advancing women's inclusion and empowerment within her community. And we have Claudio, who is a senior humanitarian leader with more than 25 years of experience across Africa, Asia, and the Middle East. Welcome to the panel. We'll start with you, Nabila. As a human rights activist and as a leader of a civil society organization yourself, are there any learnings that could help us inform how women could lead in future?
Thanks, Nishita. Hi, everyone. How is everyone feeling after lunch?
Very good, great. Okay, so I think we have the difficult job in keeping you guys a bit entertained. So I think this is also a good time to maybe put the disclaimer out there that I'm not a humanitarian worker, or I'm also not from the medical field. I'm more from the human rights space. But interestingly, in Sri Lanka, with the context that we work in, the human rights and humanitarian space kind of closes the gap a lot, especially in crisis situations. If you look at the economic crisis, the political crisis, where there was also a medicine shortage during that time, and even very recently with Cyclone Ditwa, how women have had to come to the front lines to really respond quickly. And I run a young women's organization called Sisterhood Initiative, which I founded in 2020. And at the time when we came together, it was just to create spaces for young women to come together and have conversations and learn about the Muslim Marriage and Divorce Act, where we have lots of issues like women can't sign marriage contracts, there's no minimum age of marriage, and issues like that. But today, 6 years later, we find ourselves responding to almost every little crisis situation. During Ditwa, we remember once when we were running a very short grant, and it was such a intense time where, because the community was struggling, our donors were asking us to use some of our line items to support people. So that was like one example I'm giving you is like where we had a mental health line item for our staff, because our staff is also responding to frontline victims and survivors of domestic violence and things like that, where we had to just say, okay, no, it's fine, we have to feed people. People don't have food. And often when we see women coming to the front lines like this to support and work, we think it's just women providing care work, because that's what women do in families. We make sure people are fed, people are taken care of, people have a bed to sleep on. But this work is also, end of the day, it's work. And what I've noticed is that that gap is closed really quickly. And also, we don't have a lot of the skills that humanitarian aid workers have. Like, for example, you've heard a lot from the speeches at the spotlights. It's like, it's so much of resilience that they have to carry, where we are more like researchers. We do treaty body reporting, we do human rights reporting, advocacy. And now suddenly we have to respond to people saying, I don't have food, I can't sleep at night, there are mosquitoes biting me, and things like that. I remember during the economic crisis, the first time we were like put into the deep end when we had to, one of the communities we were working in the Slave Island area, we had to go back and provide them with dry rations. And that was my first time. Despite having experience being an activist, I had to close the door of the church because we had run out of rations. And at that moment, I just thought, my gosh, like I'm closing the door to people who want food, and they're banging at the end of the door. And I was just thinking, like, these are positions that we're put into. We don't have the skills, but yet we kind of work and we serve, and we also really need to like fill that gap. And I guess why I'm trying to say this here is also because of the kind of context we're working in, and because we spoke about care work and how women are providing this kind of service as if like it's just like something we do as women, but also it's required of us also at the end of the day. Yeah, I think I'll leave it here, and then maybe I'll add a few more things once we hear from Noor.
Thank you. Noor, from your experience of working with women in your community, do you see that systems are designed to equip women to lead, or do you see some systemic barriers for women?
So one of the biggest things that I've seen in my community is that the Rohingya women are the ones that are carrying the responsibility for the health and well-being of their families. And it's become normalized, you know, in the Bangladesh refugee camps and in Indonesia, and even in the other diaspora communities in South Asia and Southeast Asia, in Malaysia and the rest of the world. But they aren't given the power to make the decisions about the systems that shape their health. I was in Cox's Bazar last week, and I really just saw how much the responsibility falls onto women. especially with collecting rations, collecting water with the water jugs in that 1 hour time that they have to get clean, safe drinking water, and carrying it back to their homes, and taking their children to the clinics and hospitals to get medical care. And to us, these may seem like everyday tasks, but it's a form of invisible labor, of unrecognized labor, right? And it's also a form of leadership and care that keeps families and communities functioning. And there was one particular interaction that I had in which a Rohingya woman, she came up to me and she told me about how 2 of her children were kidnapped in the camps and had been trafficked to Malaysia. And she was very worried, and she came up to me desperately asking for help to see if, you know, we can find out any news about her children. And she's not asking for anything extraordinary. She just wants to know whether her children are safe, whether they're okay, whether they've eaten. And what immediately came up to my mind was, you know, like, what Rohingya mother doesn't love her children? What mother wouldn't want to know those things? And it also reminded me that when we talk about health, we can't separate it from safety and dignity and security. And we also have to recognize that many of the systems we ask women to participate in were not designed for them to participate in, right? Healthcare systems, humanitarian structures, livelihood programs, and decision-making spaces have often been shaped by those who hold power, while marginalized voices and women's voices have been excluded from shaping them. And I know that in my community, our women are incredible at having an understanding of what their communities need. They know what prevents women from accessing healthcare. They understand how safety, livelihood, and education and health intersect with each other. That knowledge is their expertise. And this is where I also think that the humanities becomes important to global health. And I think Dr. Roshni also kind of mentioned this earlier in her presentation, is that we have to ask who gets to define health, who gets to define what a community needs, and whose knowledge do we consider legitimate, right? Because health goes beyond whether somebody has access to a clinic or not. It's also whether a mother has the economic agency to provide for her family, whether her community is safe, whether she can make decisions about her children, and whether she has a voice in the systems that are affecting her life. And especially for Rohingya women, the leadership already exists within our community. As you saw Showkat Ara speak earlier, she's already doing what she can to get education, right? And to try to learn to the best of her ability. So our responsibility is to create the conditions where that leadership can grow and flourish, and where women have the authority to act on what they already know. Because ultimately, we shouldn't have to convince anyone that a Rohingya mother loves her children, right? Or cares about their health and safety. That's universal. And I'll just end with this question, is that, are we ready and are we willing to build systems that give her the power to protect what she loves, shape the healthcare her community receives, and shape the future of her own community?
Thank you. Just another question to you, Nurhat. You spoke about the power imbalance that comes in when women are not on the table where decisions are being made. You spoke about the intersectionality of various reasons why women can be pushed further into marginalization. Your organization works with a lot of different stakeholders. Would you like to touch upon how your organization and you have been able to elevate Rohingya women into leadership roles or bring them on the decision-making table with your work?
Yeah, sure. So first of all, Rohingya My Funder Collaborative Network in itself is a Rohingya-led, women-led, and refugee-led global network. We started out with 5 women, and now we have 15 women, strong, fierce Rohingya women that are from all around the world. We have members from America, Canada, India, Pakistan, and Australia, and we're looking to expand even more and create a network of Rohingya women from all around the world. And our work begins with listening to the voices of our community and amplifying their voices in whatever spaces we enter, whether it be with the government stakeholders or even our partnerships and collaborations with civil society organizations and people on the ground. And one of our focuses is that instead of coming into the community and identifying who should be leaders, we are building the capacity of our own community and our own women and creating opportunities for our own women to lead. Because we recognize that Rohingya women are already leaders and advocates and organizers in their own homes. So we're trying to build on that existing leadership and give them the tools, the confidence, the resources and platforms to turn their lived experience into decision-making power. And as a small organization, due to the funding cut, we've had to step in terms of humanitarian efforts to, kind of fill in that gap and ease the burdens of the host communities in terms of, providing emergency aid or, access to health care. And a part of those donations actually also went to implementing programs for Rohingya refugees in Bangladesh and in Indonesia. So one of the things that we jump-started when we first started out was, after we visited Indonesia, was to train and mentor the youth, especially women and especially the young girls, for basic life support and identifying mental health crises, and basically be first responders within their own communities to be at the front line of their own people. For their own people when there are gaps, from the NGOs and other organizations that are helping them. Another program that we have that's still active now is a sewing program in the Bangladesh refugee camps called Threads of Resilience, where women learn how to sew with the sewing machines. And after they learn the sewing and go through like that training program, that sewing machine is actually given to them so that they can, as a means of earning their own income and having that agency and not being very dependent on aid, because at the end of the day, we like humanitarian aid will only go so far, right? So it's building that capacity within. Another program that we have is a literacy program for women where they start to learn their ABCs and then they learn how to write their names and even their children's names. And again, that's one of the key building blocks of leadership, right? Enabling them to become advocates and health workers and organizers and teachers later. And as a network, one of the things that we also push is for young Rohingya girls to see that their identity isn't a limitation, and that their lived experience and the knowledge of their community and their identity as a Rohingya woman can be a source of leadership. And ultimately, we're trying to build a future where we don't have to constantly look outside of our community for people to lead us. We're investing in our own people, uplifting our own women, and building the capacity within the community itself.
Thank you. Thank you. So, as you know, this panel is about care without power. Whether it's crisis, conflict, wars, disasters, women are often employed in more frontline jobs as community health workers, as midwives. They may serve as doctors or nurses as well. It's just considered to be their job to care for others. It's not really looked at as of something with economic value. However, and this is where, Claudio, we would love to hear from your experience in Afghanistan, where you lead MSF's operations. And Afghanistan is where MSF has had one of the oldest operations in all of South Asia. There has been a systematic erasure of women from any formal spaces, from public life. Could you help each of our audience members today visualize what it means inside a hospital?
Yeah, thanks a lot, Nishita. And yeah, as you mentioned, I currently serve as country representative for MSF in Afghanistan, where we have a massive operations. We've been there since 1980, actually. And we are covering a quite big area of the country with the hospitals and medical activities and so on. So my perspective today is more operational, practical. I'm not an expert in women leadership as a concept. So I will take this question from this angle by suggesting that one of the greatest challenges that Afghanistan is facing today is not simply the absence or the exclusion of women from formal leadership and decision-making positions. From this, it's mainly, it's not mainly, it's also the gradual erosion of professional and educational pathways that allow future leaders to emerge. And from this perspective, I would also suggest that leadership and professional career follow a process. So leadership, for example, is cultivated over years through education first, then it grows through mentorship, it develops through professional practice and matures when people are trusted to make decisions, right? And in every health system, in every system, since we are talking about health system, in every well-functioning, healthy health system, there are educational, professional, and leadership pathways that eventually produce leaders who shape institutions. Well, these pathways in Afghanistan for women and girls are denied. So, they are progressively narrower and narrower. Just to provide a bit of context, I will not dig more. I will not be able to provide, because of the time, a broad overview of the context. I will focus on one point mainly. So one defining feature of the current context in Afghanistan is the progressive expansion of social regulation. So I'm talking here about bans, restrictions, decrees, impositions, morality policing, and so on. these restrictions are affecting many aspects of the public life, including education, employment, mobility, professional development, and participation. And women and girls are particularly affected by these restrictions with severe and very concerning implications, not only for individual rights, but also, and for us is the main concern as medical and humanitarian organizations, for the long-term resilience of the health system in Afghanistan. Just to dig a little bit more on these restrictions. So we mentioned restrictions on employment and restrictions on education, ban on employment and education. The one on employment has not been extended to the health sector. That's also why we still have in our programs 43% of our workforce which is female, and which is around 1,600 Afghan women working with us with different positions, from medical doctors to nurses, midwives, and others. But what is extremely concerning is the ban on education. Girls are banned from accessing and attending secondary school, university, and other medical schools. Just to make an example, it's been more than 2 years that there haven't been any newly graduated female doctors in Afghanistan. We believe that in the long term, the consequences of this could be catastrophic, actually, for the health system, and it's the effect of that is already visible in our hospitals. So we're facing some challenges. For example, it's quite challenging already to recruit qualified staff for some specific position, like gynecologists, nurses, specialized nurses, and so on. But the issue is not only a matter of recruitment. It's a matter of preserving the human capital and take every opportunity, explore every path for learning, and invest more and more on education, mentorship, and so on.
You just mentioned that it could be catastrophic in the future with that gap increasing. We were talking about the economic value of women's work when they get into leadership positions and how they could design systems that are equitable for other women. But I want to flip that question. If in 10 years things were completely different, how would you reimagine, or how would you envision, if women were in leadership roles in health and humanitarian sectors, what would it mean for a person trying to access care in Afghanistan?
Well, it's good that you mentioned access to care in Afghanistan. I think that someone this morning also mentioned this part of access. So access, we tend to measure access in terms of patients reaching our facilities, right? but there is also another form of access that is equally important, which is access to education, access to mentorship and career development, professional development, and so on. We said catastrophic. Catastrophic because there will be no professional women working in the hospital, and we know that in a place like Afghanistan, it is cultural norms that female patients are treated by female medical staff, doctors, nurses. So it's also a contradiction, no? This ban on education. And we're trying to raise this concern with the relevant authorities, and I will stick to the practical and operational aspect, no? Trying to share also what we've been doing, because we do realize very well that this is going to be very, very challenging in 5 years from now, if we don't replace, if our nurses, midwives, we don't have so much challenges about midwife, but doctors and some other positions. First, we continue engaging with the authorities through advocacy and raising this concern with a medical ground, and highlighting exactly what we've been saying, and also the economic aspect as well, and somehow we have some people who understand what we are saying, and they're actually saying that they share the same concern, no? But in Afghanistan, it's always the reply from authorities is always that the top leader is the one deciding everything. So they have their hands tied, which is also another challenge, part of this complexity of the context in Afghanistan. But somehow we are breaching some doors. And then the other line that we've been working on, it's investing in some initiatives that we are about to launch, actually, that hopefully will have a positive impact in the future few years, with the support of the authorities. It's not something that we are doing in secret. We are doing it in plain light, with the support of the authorities as well. And that's another part of the context. No, there are few dimensions when we talk about authorities in Afghanistan. There is the official one where everything is banned. Everything. Oh, sorry. Everything is prohibited through decrees, banned. But then there is another more underground dimension, a lower one, where things are happening. And so we are trying to navigate in this complexity to find a way to gain something out of it, with the support of some authorities as well. Now, without attracting attention to that level, otherwise we'll be entering this prohibitionism. Going back to the point of what we are trying to do in terms of investing on educational initiatives, we have launched, or we are about to launch, together with our internal mechanism, which is MSF Academy, a program for professional development for our nurses. We are focused on nurses at the moment. Then another initiative is to engage with the universities and institutions outside Afghanistan, and Sri Lanka could be a very good place to do that. And then trying to see if there are some opportunities, not for our staff, what I was saying before, not to preserve the human capital, to provide opportunity for our staff, at least to grow professionally. One of our colleagues at the beginning, when she was talking about Afghanistan, she mentioned one point that is very, very true, that the students, university students that have passed all their exams, but not the final, the so-called exit exam, they have all the qualifications, but they don't have the final one to be able to exercise the profession of medical doctor. And so they're blocked. They cannot. So they are obliged to do another job. So we are trying to see if there is a way to open up for the recognition of their qualifications, and it seems that there are some possibilities on that. And as soon as I go back in 2 days, I have to discuss with my team also to see if there are some progress on that. And then another initiative, we are looking at the family of our staff as well, because it's not only our colleagues working in the hospital, it's also the daughters of our colleagues. So we are looking at that in terms of trying to see if there are opportunities for them to develop their studies, because after 12 years old, girls are banned from accessing schools.
Thanks, Claudio. Very interesting point you made just now about partnerships with different types of stakeholders, especially in Sri Lanka. And earlier you mentioned a pathway, which is education, mentorship, and leadership. That's correct? Yeah. Okay. That's actually a pathway that, Tabila, you followed in your life as well. How do you bring women as equal stakeholders when it comes to taking decisions?
And I think when it comes to decision making, something from Ditwa also that we noticed was when we were working with a very conservative village in central province, at the beginning, when we said, okay, what are your requirements? What would you like? They said, we need mattresses, we need nets, we need all of these things. But by the time the funding came in and we were allowed to, buy things, they quickly changed their requirements. They said, actually, we still need these things. We need dignity kits. We need these items for ourselves as women. But school is starting next week, and our children don't have uniforms. So scratch everything we just told you. Can you buy us school shoes? Can you all buy us school uniforms? These kids need like ties and things like that. And I think giving that kind of agency to that community, because we have funding constraints, but being able to speak to our donors and say, actually, no, they want to buy these things. And it also signals something about the women in that community, that even in a time like that, they were putting their children first, despite being the most needy at the time as well. And that is that really difficulty in negotiation and decision making that really comes, that we just see in that time period itself. But I would also like to talk about some other things when we talk about healthcare in the larger scale of women's rights, when we talk about our bodily autonomy, our agency and things like this. End of the day, everything is a healthcare. It's an access to healthcare. And this is where I kind of have a love-hate relationship with WHO, because as activists, we use WHO terminology a lot. For example, when we talk about preventing harmful practices like child marriages, female genital mutilation and cutting, we use WHO standards. So for child marriages, it happens in Sri Lanka because there is no minimum age of marriage for Muslim children. And also culturally it happens even in non-Muslim communities. But for something like FGMC, female genital mutilation, cutting, circumcision, in local terms it's known as sunnat and khatna. We are using WHO terms, type 1, type 2, type 3, type 4. And type 4 is very prevalent in our communities, in the Muslim girl population. And there is a lack of awareness on it, there's a lack of education on it, and even when you raise it to the state, they say, we have a 2018 medical circular that bans it in public hospitals. So what happens when you ban it in public hospitals? It goes underground. So you have women in the communities who are doing it, who are cutters, practitioners, ostomamis, and people like that. And a recent study in 2025 that was published by Women's Action Network, which interviewed 998 participants, it shows that it's happening. Almost 50% of that study, of that respondents have said, yeah, I know someone who has either undergone it or I have undergone this practice. And about 30% of them said, I will circumcise my daughters in the future as well. So it's showing the prevalence of the practice also in 9 communities of this country. So there is such a connection like to this current lived reality we're living in also, that the crisis is like so imminent. Like we have to stop harmful practices. We have to come to terms with how we are dealing with things. And I think Dr. Karan also mentioned earlier in his spotlight speech, sometimes he finds himself like negotiating. He's using, instead of using medical terms, he's using religious terms, and he's speaking to religious leaders. And we also often find ourselves in that situation. We are interpreting Quran, we're interpreting Hadith, and we're telling our communities, look, it's not in our texts, it's not in our practices and things like that. And these are the harms that come across if you continue to do things like this, and this is how we can protect ourselves from it. The study also shows a lot on medicalization, that it's happening in private clinics. It's promoted on social media as something that's good and that's clean. And as activists and as people in the rights space also, we have a duty to bring this to the state. And that's why in beginning of last year also, in Sri Lanka's review at the Convention on the Elimination of All Forms of Discrimination Against Women, CEDAW, in Geneva, this was again brought to the attention, and where the state replied, yeah, we have a circular banning it, and it's not supposed to happen, and it's mentioned in the penal code and things like that. So there is a huge requirement for political will also, and like a strength from the medical community also to put a stop to it. And this is where we see like lots of actors, where it's women's rights activists or community leaders coming together and saying, okay, we'll take a public health angle, we'll take a community angle, we'll speak to the religious communities, we'll speak to the medical professionals and workers and things like that. And that's where I'm seeing the healthcare angle also when it comes to women's rights and agency and decision making also.
Very, very important. And Nabila, you just mentioned the kind of actors who are important in this. Fortunately, we have representation from all of those actors in the room today. So my last question to each one of you is, if very briefly in just 2 lines, if you were to tell each one of the stakeholders in the room today, how do you envision the future of women's leadership in health and humanitarianism, what would you say? We can start with you.
Well, I would repeat exactly what I said before about education, and one of the reasons why I came here as well, it was to start engaging with universities, institutions, representative, in order to see if there are possibilities for our staff to have opportunities for education, for professional development, and so on. And then from our side in Afghanistan, we will try through advocacy to make sure that this qualification, these diplomas, this certificate will be formally recognized. So we're trying to work on 2 different lines, very much interconnected. So envisioning this in Afghanistan is also very challenging currently, but thank you.
For me, for envisioning, it starts with changing, changing the systems, and that means that organizations and NGOs like MSF and other big organizations starting to look in investment in not to just simply design programs for women, but also investing in women, investing in women's organizations, education, leadership, and compensating women for their expertise, creating safe spaces for women to organize and speak, and ensuring that women have a real influence over decisions and resources, and kind of working that into the humanitarian framework of when we do humanitarian efforts and aid, how can we also kind of work in the framework of, like a long time, like kind of looking into investment into agency and capacity building and being self-reliant and self-sufficient. And in the Rohingya context, it's extremely important and meaningful to me because we simply do not want to survive in displacement. Eventually, we do want to go back to our homeland in Burma, Myanmar, in Arakan, and rebuild our nation, rebuild our infrastructure, our health systems, our schools, right? Once it's safe for us to do so. And that future that we want to build cannot be built without Rohingya women being at the center of it.
We have to center our frameworks around accountability. I can't ask you to be accountable to me. Accountability is a standard I set for myself. And as organizations, institutions, workers, we have to maintain that sense of accountability. And even larger organizations like MSF are not immune to those problems. I think we have seen it in the Sudanese women, refugees who made allegations against MSF aid workers in East Chad, right? And the way MSF also responded, the statements, and we will make mistakes. It's the way we respond, it's the way we move forward. And it's the way we build these frameworks where we put victims forward, we put survivors forward, put patients forward, and not center these stories around us. Like, we are not the center of all of these movements, especially in the women's movement, in feminism. The main thing is to question power. But if we stop the power questioning with ourselves and we say, no, we are immune to making problems, we are immune to causing issues, then we are causing that same patriarchy, we are causing that same power issues. And I think at the beginning of this session, I didn't know about this quote by Louis Pasteur where he said, one does not ask who suffers, what is your country, what is your religion, right? But we have come to a position, even in Sri Lanka at the beginning of the pandemic, people were asked, what is your race, what is your religion? And people were not buried during the pandemic, people were forcefully cremated during the pandemic. And there were communities that really suffered. And that kind of discrimination cannot exist in the medical field, in a field that is run by science and data. And that level of accountability needs to start with us, and we have to hold ourselves accountable and ask for that justice. Thank you.
Thank you. Now we open up for some questions from the audience. Yes, can we have, yes.
Thank you. Two questions, one to Claudio. Claudio, you know that the first Taliban regime lasted for 5 years. And as soon as the downfall happened and you saw the little girls go back to school, the resilience was evident. But this has already lasted 5 years. So you already have the girl child, 12-year-old, now 17, with no access to education. Do you think these reformers you're talking about, what kind of incremental change are we talking about? Second, so it's very nice to talk the talk, but 5 years have already gone by. To Nabila, you have had a political change in Sri Lanka. do you see there are more advocates now that to support the kind of work that you're doing than they were a few years ago in decision-making circles within Parliament? Thank you.
Well, I don't have an answer on this question. I mean, yeah, it's true. It's already been 5 years of restrictions, and the outlook is actually tightening, a gradual tightening instead of a sudden collapse or a change of direction. So we are going to face difficult moment, even more difficult than now. And we're trying as much as possible to find a way, at least for our female staff, to provide some opportunities, some hope also for them and for their families as well. It's not going to change the whole system. For this, there is a need of a radical change. But for that, for now, I cannot even imagine something like that happening right now. We have to continue fighting and diplomatically engaging also with the relevant authorities to try to find a way to make some changes, knowing that it's going to be difficult. It's not going to be easy to change their mindset, and so we need to work together with other organizations as well to advocate for the same. For now, that's why I was saying my perspective is very much operational and practical. No? So we are trying practically to find some ways to at least provide some opportunities for our staff and for their family. Considering that we are working in 10 provinces in Afghanistan, so not everywhere, but at least from our perspective, at least we can maybe give an example, and it's not only us doing these sort of things. Other organizations are doing more or less the same. So who knows? Maybe that will be the chance to really find a way to raise this concern. We've been working on other initiatives as well that I'm not going to mention because they're more, they're not official now, but we would like to engage with higher level in Afghanistan to raise this concern from a pure medical ground.
Yeah, I think it's overall, like, if obviously are going right after Afghanistan, like I can't make major complaints, but it's like, overall it's so much better. I think all of us will agree from the right space that there is less repression and things like that, and there is more representation of women in decision making, especially in Parliament. But end of the day, what we want is not more faces. We also want more decisions being made. For example, in Parliament, we have Malayaha community representation. We have women from the Malayaha community, as the estate Tamil community, in Parliament as parliamentarians, but I have personally not heard any concern of the community heard on the floor in Parliament. And that's what we are wanting. We want to see something happen. We want to see some changes. And it's not to say it's not happening, because it's also a short time. It's been 1 year, 2 years. But I think we want to see something happen, and that's not what we're seeing. But also, I also have to echo, as civil society, we are seeing bills being brought to possibly create more repression, like 2 CSOs and things like that, like Dr. Sakuntala just mentioned in the previous session. So we're watching, and we're just waiting to see how we should also respond back.
We can take just one more question.
Well,
I might sound like a devil's advocate, but when it comes to gender definition of leadership, my always worry is that we are sometimes falling into the trap of what we are already fighting to escape from. And that goes to everything. I mean, it is like, it's becoming, what I'm trying to say is like, are we still changing the narrative if we don't find for equitable opportunities to educate, equitable opportunities for work, whether we are men or boys or transgender or whatever sexual orientation? And wouldn't that be what we should be aiming at, instead of really defining leadership in terms of a specific gender? And isn't that what we should be aiming at? Do you get what I'm saying? I mean, it's like we consider that women can differ in leadership. The point is this should have this, it should be self-granted that they can have an equal opportunity as anyone else and be paid as anyone else, depending on their skills for leadership, being trusted to make decisions, not because they're women, but because they're capable, like any other man or woman or transgender. Should we go then in the future and start discussing like a transgender potential in leadership because they are feminine as well? You know what I mean? We are very narrowing, and I'm not sure if we are in the right path when we are defining topics just in this angle very narrowly. I understand the constraints. I grew up, my mother was illiterate, and she was illiterate because she was meant to grow a family, and she raised us considering that we should not fall into this trap. We should be standing on our feet, men and boys, the same. You know what I mean? And I feel like we are grinding a narrative that really fits in against for what we are willing for.
Thank you so much for that. And yes, we come to the close of this panel. We'll definitely have more spaces, more conversations, more debates and discussions around how do we make our language more inclusive, how do we make spaces more inclusive. Today we have focused on how do we bridge the gap between front lines and the boardrooms or seats where women hold power, but I completely agree. We need to look at it from different perspectives, make it more inclusive. With that, we close this panel. Thank you so much.
Thank you, Sarathi, and thank you to our panelists for that amazing conversation. I think, it's still the beginning of the conversation. You have given us a lot more to think about. Our next speaker is someone who knows resilience in the most literal sense. As a survivor of drug-resistant tuberculosis himself, Nitesh Yadav has conquered one of the toughest battles that can be fought as a human being, the fight to reclaim his own strength and his health. Without further ado, can I get everyone to direct their attention towards Nitesh on the storytelling stage?
Hello, hello. Okay, before I start, I just want everyone to see that picture. Can you guess that person? Well, it's me. Okay, so the journey from there to here, it's not easy, but here I am. My name is Nitesh Yadav. I'm two-time TB survivor, and I'm a teacher by profession, and I am one of the founding member of a civil society organization called TB Survivors Collective, which is based in Mumbai, India. So TB and me is related like quite for longer time, and it all starts when I was 11 years old. At that age, when I was in school, I never heard or never knew what is TB. But when I was diagnosed with TB, the only thing I remember is when my parents told me not to tell anyone that you have TB. So I was completely treated by TB, but the only thing which stayed with me for a longer time, that don't tell anyone that you have TB. I completed my treatment and I was all okay in the first time. After 6 months of treatment, I returned back to my normal life and I was okay. But after COVID was there in the entire world, all the countries were struggling. And somehow I left my teaching job because the schools were not functional, they were not ready to pay. I started working in a call center for a bank based in India. And when I was working there, that was the time in around 2021, 2022, I realized that eventually I am losing a lot of my weight. And I was not able to eat anything. And I used to get fever, mostly during night. And I used to feel weak. Okay, a person, imagine a young person of around 22 years of age, if he is feeling weak, can't walk, okay, wants to stay at home. But I still somehow, because of the condition, financial constraint, I used to go work. There was this meeting and in the space of 10 people where I have been, when I was coughing. And imagine I was scared to cough. Not because that I might have TB, but they should not mistakenly take that I might have COVID. Okay? But after few days, they told me, please don't come to the office. Please stay back home. Okay? And I went home. And when I came home, I realized that this is going to be longer. I went to the doctor, and when I went to the doctor, they said it's normal, and they started treating me for COVID, which was not the case. And after feeling better for some time, like after 2 weeks of treatment, I felt better for a little while, and I decided to go back to village because I felt that place where I won't be getting, that stigma that I can cough free. Okay, the people inside the house, they will not see me from that eyes. Okay, but the situation was getting worse and worse. At one stage, I was only left with 26 kgs of weight, and that was the high time when I was brought back to the city. And since it was COVID time, the government hospitals were already struggling with a lot of COVID patients. I decided to go to private hospital, where after, if you will see the timeline, it is almost, I'm talking about 10 to 11 months. I am living with TB without myself knowing that I might have TB. Because of that delayed diagnosis, what happened is I landed up in this condition. Okay, this is the stage where I have lost all the hope. When I went to the doctor, this is the day when I got to know that I have TB. I came home, I started crying a lot. You know, I read about TB again, and the only thing hit back was whatever I have heard when I was at 11 years old. I thought I won't survive. But after 11 months, once I got to know that I have TB, I started my treatment. And I was happy also, not for the fact that I have TB, but for the fact that TB is curable and I will start my medicine and I will be okay. But that was not the case. Once I started my medicine, my body started reacting in a very bad way. I had a lot of side effects, such as I used to vomit a lot. Okay, even after taking medicine, not a single day I have slept properly. I used to take injections alternate days for TB. And that day when I went again to the doctor, he said you should stop the medicine. And as everyone here, they know, like TB medicine we have to take in a very consistent manner. We cannot put a gap, and when there is a gap, there is a problem. Okay? Now, private hospital, they are done. And finally, they said that I won't be able to survive because they were not able to treat me. And that was the stage where I became suicidal. I felt even after taking medicine, even after taking a lot of injections, okay, I'm not healing, I'm on bed, I'm not able to move, I'm not able to talk. Then I felt it's better if I die. Then after that, somehow, the last option where I reached was Group of TB Hospital, which is one of the Asia's biggest hospital in India, which deals with tuberculosis patients. There, I was there for 2 months. When I went there, the things which changed in me was I was surrounded by 30 more TB patients who are there with me in one hall. Now I realized that every morning I used to get up, someone or the else used to die. And every day that was used to be very traumatic for me. And I used to wear mask for 24/7, that even though I have, but I used to be scared that next morning will be me. And that made me feel so scared. I told my parents or my family members not to come and visit me. And I'm crying a lot on the hospital bed, and I'm calling them and I'm telling them, please don't come to meet me. I don't want because of me. You should also get this. Because I feel when we talk about patients, it's not only patient or the person who is suffering, it's also the family member who are struggling with them to take them to the hospital or anything. Okay? But after I was there for 1 month. After that, I started showing improvement. When I started showing improvement, for example, we eat medicine in a hope that we feel better. And we feel better, we start trusting doctor, we start trusting medicine, and I start trusting the process. And after being there for 2 months, I finally started responding good to the medicine. And I came back home. In the process, when I was there in the hospital, I didn't wanted to stop my education as well. I was pursuing my master's in science, and it was an online class. I completed my education from the hospital from that bed, which I thought might kill me one day. After coming back home, I completed my education. After that, I pursued my degree in bachelor's in education, and I became teacher. And we say that we should forget whatever bad has happened and start moving on in our life. I started moving on until one day when I was teaching, I saw tuberculosis again in a textbook. So that day, it felt something inside me. I was teaching that tuberculosis is caused by Mycobacterium tuberculosis. And I felt sad for the fact that the disease which has taken my 2 years almost and made me cry, made me suicidal, everything, and there is only one line for that disease. And I was very surprised there was nothing mentioned about symptoms, precaution, treatment. So I think awareness must start from the younger age, especially from the students. And that day I kept on thinking and questioning myself as a survivor, as whatever has happened to me. I always wanted to do something for this, but I never got that path. Until one fine day, I have attended a workshop in which I met more survivors. When you meet people, other survivors, you feel you are not alone in the battle, and trust me, it is very energetic and it's very motivating also. That it's not only you who have suffered, and when I met them, the amount of positive energy they were giving, trust me, I can tell you. I felt so happy the way they were talking and the way they were telling their stories, and they were, motivating others. Like, if we can be okay, I think you can also come out, because TB is not something which cannot be cured. We have medicine. We have medicine for that. It is curable. It's only that we need to consistent and we have to complete the treatment. After meeting them, we made a group of survivors, and we decided there is nothing called survivor-led because our voices are not heard. So we came up with a survivor-led network called TB Survivors Collective. And with that network, we are mostly focusing on, it's very important that we should include voice of the survivors. As a lived experience, I know what I have faced and what I don't want others to face. At the same time, as a TB survivor, I always advocate about that what a delayed diagnosis can do to a person. So from my experience as a 2-time TB survivor, I see a ray of hope that voices of TB survivors will be heard, and we should prioritize patient-centered care. And if I'm talking about TB Survivors Collective, I think slowly and gradually we are heading there. We are taking up awareness sessions. We are doing peer support counseling. And whenever we go on field, so am I. We always tell that it's not the end. Okay? And it is also important that we give the platform where we should include TB survivors in policy making decisions as well. Okay? And and lastly, I just want to say that if there is proper care, okay, if the diagnosis is done on time, a person who can look like this can be like this. Okay? So it's all about time and treatment and support. And lastly, I just want to end with this thing that TB is curable. It just we want that we be open to the people by not stigmatizing them and by just supporting them. It's like if a human is saying one word, we say support, no? That is more than enough. I think medicine will work. Secondary, the primary support we get from the human. That's all. Thank you so much, everyone.
Thank you, Nitesh. That was an amazing story, and we are very happy you're here today. For our final panel of the day, we turn into a question COVID-19 made impossible to ignore. Access to medicine, diagnostics, and vaccines is a political choice as much as a scientific one. Health sovereignty isn't about isolation or self-sufficiency. It's about the capacity to cooperate, to share knowledge, and to build regional manufacturing while staying connected to global research and solidarity. Moderating this final panel, let's welcome Nadim Majid, our campaign manager for MSF South Asia, Joining him on stage are Dr. Abe Shukla, the national co-convener of the People's Health Movement in India, also a senior scientist at SATI in Pune, Dr. Palita Abekon, member of the Global Pandemic Monitoring Board, and Prakriti Dakal, personal undersecretary to the Prime Minister of Nepal.
Check. Hi. Big thank you, first of all, to everyone who's stuck around with us through to this final panel discussion for the day. It's good to see a nearly full room. Thank you, everyone, also who's joining us online on the live stream on the MSF South Asia YouTube channel as well. So Nitesh has just shown us what it costs when a curable disease meets a system that rations the cure. And that gap between what medicine can do and what people actually can do and who we can reach. And that is actually where this panel begins. So for the purpose of this panel, thank you very much, Prakriti, Dr. Palita, and Dr. Abe for joining us. I'd like to begin with probably one of our most experienced speakers today, Dr. Palita Abekon, former WHO regional advisor for South and Southeast Asia. You have spent decades inside the global health and public health system inside the WHO and across South and Southeast Asia. From that vantage point, how has this region's ability to guarantee its own people access to essential medicines changed over your career? And where does real decision-making power over access actually sit today? Is it in the capitals? Is it in Geneva? Or is it in corporate boardrooms?
My goodness. Thank you very much. Thank you for inviting me.
Yeah.
Is it okay?
You have to hold it a bit closer.
Yeah. I'll just try to share a few points which I can recall from what I did. Nothing very special. Most of this you all know, so it will be a little repetitive. If you ask me, overall, over the last 2 decades or maybe even 3, the situation with regard to medicines, availability of medicines, and accessibility to the people has improved. Has improved in most countries in the region. But each one has its own story to tell. 2 things which I think prompted this and stimulated and triggered these developments. One is, of course, the concept of universal health coverage, which came before, but ultimately got crystallized in 2015. After that, this became a matter of focus attention. This was on top of what WHO and the other countries had agreed as the essential medicines list, which I identified a long time ago. But over the last 20 years or so, this again triggered some of these developments. As you know, universal health coverage has 3 components, one of which is who is covered, the coverage in general. Second is what are the services which are covering. And thirdly, what is the cost? Now, the countries which have done pretty well over the years with regard to getting their people the medicines, essential medicines particularly that they need, most have done well, but I think particularly Thailand is one country that has done very well. Bhutan and Maldives continue to do well because their healthcare is entirely or mostly state-funded. Thailand because of their national insurance scheme, which came in 2003. Thailand, as some of you might recall, was a country which had the highest out-of-pocket expense in this region, almost 85%, 75-85%. And that's why this transition came and a lot of people worked on that. Now, my own country here, we have done well in the sense that we have total coverage and anyone can go to any hospital and expect to get treatment as well as the medicines. But of course the story is not that straightforward. While coverage is available, we also have a fairly large private sector. Not in terms of the numbers who go there, but in terms of the costing. And right now, I think the latest figures, I saw Dr. Sapumal here, he should know this more than I. I think our out-of-pocket expense is almost 50%, close to 50%. The good thing about Sri Lanka's out-of-pocket expense is the fact that this is mainly, number one, borne by the richer people who go to the private sector. Number two, it is mainly due to laboratory examinations that people pay for. Even people who go to the government service, sometimes they have to go and get, and for the medicines. So it's not equitable out of pocket, but it is not totally damaging to the poorer people. But still not good. We have a long way to go to improve this. The reason why, some of these other reasons why the coverage and the availability of medicines increase is because, number one, more and more countries went into local manufacture, particularly the larger countries, India and Bangladesh, which are now become practically together provide 70% of the generic medicines to the whole world now. And our countries, we benefited by it. But our countries also have expanded our local manufacture. For example, in Sri Lanka, the local manufacture covers almost 75% of the medicines, not totally. But totally, if you take the medicines market in Sri Lanka, the private sector, the local manufacture covers only about 20%. So most of it is still imported. But Sri Lanka has a system where we have a fairly tight control on the prices. Therefore, the prices have not gone through the roof, except, of course, the newly the patented drugs which are coming and which also our people try to control a little bit. The people's movement in Sri Lanka is also quite active. They keep an eye on this. So that's how the situation is. But we have a fairly long way to go. And it is a constant struggle. We don't have all the answers. The other question you answered is, asked me is about who controls,
Where is the decision-making power?
Yeah. It's like this, let me say, ultimate decision-making power is in the country. As you say, the word capital. Because of money and the sovereignty is in the country. But it is, again, not that straightforward. As we have seen in the last few years, particularly with the COVID-19, a lot of the decisions were not made in the countries. In fact, they were not made even in Geneva, which sets the normative rules of the game. They give the prescriptions for what should be, but it's not what happens. The richer countries who work hand in glove, I'm saying this I'm making a very bold statement, but there are all exceptions. But in general, the pharma lobby and the pharmaceutical companies are the ones which set the table in this agenda in this. As we saw, for example, you have the situation in 2021, I think, where some of the people in the richer countries had 4 doses of COVID vaccine, including one booster dose, whereas some of the people in Africa didn't have a single, before they got even a single. So after that, I want to take one more minute and then close the cycle and I'll shut up. Yeah.
No, go ahead.
Yeah, because of that, most countries and most regions got very, very active to develop their own regional and national vaccine programs. The most effective work obviously has been in Africa because that is the worst affected. Africa has a very good program now with a good regulatory authority in South Africa. Our region, of course, we depend on, for vaccines, we depend on the Serum Institute of India, which is a powerhouse in vaccine production. Our vaccines we were not deprived badly and not too long because Serum Institute India came to our rescue before even the COVAX kicked in. The COVAX gave some money and we also got vaccines from China in concessionary way. So Sri Lanka in particular was not badly affected. We had most of our people getting vaccinated. But this ultimately has triggered. Africa is now on its way to produce its own vaccines. Thailand is doing that. India, of course, continues. Indonesia is doing that. And twice, if you ask me the other question, where is the power? During COVID, there are only 4 compulsory licenses that our people, only 4. And they were for the medicines, not for vaccines. 4 of them, in 3 countries, the same medicine. So it's not 100% good, but we have the opportunity and the framework exists for us to overcome some of the TRIPS regulations in cases of public health emergencies. And our country should be able to do that more.
Thank you. Yeah, thank you, Dr. Abekun. I'd like to come back to you later on the post-COVID-19 world, but I think on your note on decision-making power and how it is not that simple, I'd like to move to Dr. Shukla, actually, who has been a long time advocate of the position that public health is being increasingly reshaped by corporatization and financialization. Now, to many in our audience, especially with a public health background, those terms will make sense. But we'll also have from those who are not from a public health background who think, okay, what do you mean by corporatization and financialization? So can you help us make them concrete? What does the financialization of the healthcare actually look like on the ground in India? And why is it that you consider it a central threat to healthcare sovereignty rather than a side effect?
Thanks a lot. So I'll start with an example. 3 days back was 15th of August, which is Independence Day in India. That's the day we became independent from the British in 1947. On that day, I made a presentation. And the opening slide was Happy Corporate Hospitals Dependence Day. Dependence Day. Today, the top corporate hospital chains in India are no longer owned by Indians. Manipal Hospital's 74% stake is by foreign transnational investors. Fortis Hospitals is 57%. Max Hospitals is 52%. Apollo Hospitals is 43%. They're no longer Indian firms. The names are Indian, the managers are Indian. They have essentially been taken over by foreign capitalists. Please note my words, these are the biggest hospitals which have tens of thousands of beds in many of these chains, and they are no longer Indian. What does this mean for the sovereignty of India? So, coming to your point, what is corporatization and what is financialization? Today, actually this process started or accelerated during the last roughly 1.5 decades, when till then we had privatization. We had large private hospitals, we had even some private hospital chains like Apollo, but what changed was the nature of investments. These were not, till then local banks, Indian banks, maybe some other NRIs were giving funds. Large transnational private equity, which has no roots in health. Names like Blackstone and KKR and Carlyle and TPG started coming into the picture, and they started investing huge amounts of money in these corporate hospitals chains with only one objective. These are not charitable institutions. These are private equity firms. These are sovereign capital institutions with the sole purpose of extracting maximum amounts of profit. On the surface, it looked good because a lot of money was coming in, but we did not notice how much more money was going out. So you would have read quite a bit about investments coming in. Have you read anywhere about what amount of profit has flown out of India? I'm pretty sure it's unlikely. If anyone in the audience has read about this, please let me know. In my understanding, our national study on corporatization of healthcare has for the first time calculated the scale of resources flowing out of India to transnational foreign investors. The amount in the last 12-13 years amounts to, from just 12 hospital deals, and this takes place through entry, capital appreciation, and exit deals. So it's not seen as, normal dividends. They come in, they buy something for 100 rupees and sell it in the market for 500 rupees. The total amount that has been extracted out of India in last 13 years is 1 trillion rupees. 1 followed by 12 zeros. That is larger than the annual total national health budget of India. This is the amount which has been extracted only in the big deals. There are many smaller deals. Now, where is this money going from? This money is not appearing out of thin air. This money is ultimately being extracted from patients and from nurses and healthcare staff. And just to give an example, that today the cost of an average corporate hospital bed per day in India is 60,000 to 80,000 rupees per day per patient. In Sri Lankan rupees, that would be something like 250,000 to 300,000 Sri Lankan rupees per day, per bed. Now, can you imagine the scale of if a patient is in a hospital for 10, 15, 20 days, the lifetime savings can be wiped out. So this is the scale of extraction that is going on. And in COVID, this was multiplied. Until COVID, we had market failure. During COVID, we had market disaster. And I don't want to tell you, we did some studies and we did a lot of analysis and we helped a lot of patients to recover excess bills from private hospitals by getting the government to audit their bills. There are many stories behind it, but just to sort of summarize what happened is that huge amounts of overcharging was also taking place. So please note the point that under corporatization and financialization, a peculiar new form of extraction has emerged. Until then, there was profiteering. Now, there is super profiteering with extraction because something called patient captivity has now come into the picture. There's something called ICU. 15, 20 years back, ICU admissions were a rare thing. Today, almost every third patient lands up in the ICU, and the ICU is like the patient is captive, quote unquote captive. The family cannot meet the patient cannot speak to the family, and the doctors and everybody keeps saying, no, your patient is in the ICU and things are going on. You basically cannot do much except keep paying the hospital bills, and in the end, there is a huge hospital bill. Many of these are in corporate hospitals. Now, this corporatization and financialization is not limited to India. It has spread to Nepal, it has spread to Bangladesh, and unfortunately, it has also spread to Sri Lanka in an initial form. So the two interesting stories of Lanka hospitals and Asiri hospitals. Somewhat two different stories, and the Lanka hospital stories show how the government is now trying to sort of reclaim something which had actually gone into corporate hands. That's a different story which you all must be knowing, but the interesting point is Apollo started that story. And then finally Apollo had to withdraw. But today, transnational capital is penetrating the healthcare systems of many countries in South Asia. India is in the most advanced case, but it's also in other countries. And this is linked with another phenomenon called hegemonic commercialization, which means corporatization is not limited to the corporate hospitals. It reshapes the market. The entire market starts getting much more commercialized. So charitable hospitals, small hospitals, individual practitioners, they also start behaving in much more commercialized ways, and that has a very big impact on negative impact on society. So to conclude with, your national animal is the elephant. The corporate healthcare sector is like an elephant. If the elephant is controlled, probably it can do some good work, probably. If the elephant is left to its to itself, then you can imagine how much damage an elephant can do. So now we are living in the era of corporatization. We urgently need to analyze this, we need to regulate it, and we need to resurrect public systems, which are basically the main point, which I'll maybe come to later, that a much larger recognition is required. And just while concluding, I'll point out this is a recently published book on corporatization of healthcare in India. The subtitle is How Big Finance is Destroying India's Healthcare. So please don't look at India as a good model. The current corporatization of healthcare in India is a very problematic situation.
Thank you, Dr. Shukla. I'll get back to you on how we grapple with these corporatized or financialized models. But before that, Ms. Thakur, if I can ask you, you're sitting right now at the center of policy delivery in a government, an emerging administration in an emerging country that is trying to find its own direction and define its own direction as well. So Nepal is a comparatively smaller market. Not small, comparatively smaller. And there are real constraints as well. So negotiating for the same pharmaceuticals, medicines, as far larger buyers as well. So from inside government, if you could let us know what does healthcare sovereignty actually look like as a practical agenda rather than a slogan, and where does a country of Nepal's size actually have leverage?
Thank you very much. I was listening to two of the very experienced and amazing personality, not just within India and Sri Lanka, but I think throughout the region, South Asia and globally. I'll try to connect. Before coming to here, I asked a question to Dr. Palitha. Since you might know more about Nepal than me, so what do you think about Nepal's healthcare system? He worked in Nepal for a couple of years in medical education for more than 3 years, he said. And I'm buying it from him. I will share what I'm thinking, but he said it's improving in terms of access and availability a bit. So I learned, and then taking it from him, I also think it's improving to some extent, but I'll add a bit more on that. And also getting into Dr. Avek's perspective towards privatization of healthcare system, I feel much relief sitting in this chair, because I represent here, I would like to represent here as a public health professional, as an academician, not actually a government representative. Because if I stay here as a government representative, I might get a little, reserved on answering certain questions. So I'd like to give that as a disclaimer. There's one young health professional seated next to two amazing, experienced professionals and sharing her experience. Now connecting to both of them, and now getting back to, you said, evolving administration. Very interestingly, I am the youngest undersecretary of youngest sitting prime minister of the world, which is also very fun and interesting experience, being able into the center of policy making. As there was a question asked about the power to Dr. Palitha. I define power dynamics into 3 different phases of power, which I will later on add that perspective here as well. First, second, and third dimension of power. Before working in a civil society sector and areas, we're more into agenda setting, trying to give ideas and information, working as a partner to the government, which is second dimension of power. And sometimes, as a citizen and public working into a different sector, we'll try to work on the normative values. What is the idea and ideology behind certain things as discussed? What is the ideology behind letting private companies to invest in the country, or ideology behind having all run through the government different, which is the third dimension of power. Me working around second and third dimension as most of us. Now suddenly there's the first dimension of power, which is like, who decides and the decision making on the table. It's a different experience being there. Just adding through now, as you said, what the sovereign looks like for Nepal. I was reminiscing what I'm working currently in a restructuring of health insurance system in Nepal, and Dr. Abhay mentioned about heavy loaded private intervention there. There's so many pinpoint on adverse selection and other ways I will later on add. So if we get back to the structure of Nepal's constitution 2015, Article 35 mentioned that we have 3 tiers of government, federal, provincial, and local government. Federal government mostly work on the policies and the budgetary, whereas provincial government more work on a delivery network, and local government, 753 local government has a direct hands-on working in the community. So each of these government has its own rights and privilege to be exercising. So with the constitutional structure, it's both sovereign, independent to each others in terms of practices. But if we look back into certain agenda, for example, as I'm working on the insurance system restructuring itself, there's so many things that the constitution would say, but not happening. There's a certain co-payments and things local government was supposed to do but not doing it, and that's why federal is structuring so many things. So ideally, with the structure of governments, it's independent to each other and working practically. There are some of the nuances that we're trying to work on. So now getting into the next questions on about where does a country Nepal's size actually have leverage? Well, size, in terms of size, it's not small. It's ranked on a 52 number in the size of the population globally. Our population size is 30 million, so you wouldn't say small to us compared to yours, okay?
Fair.
But
so I said comparatively.
Comparatively, but small in context of market, a medical market size. Nepal produces roughly around 40 to 45% of medicine which required for it, and the rest of its exports from we get it from India. So this new government, especially where a couple of us have direct hands-on experience trying to expand local manufacture of medicine. So we used to get only 11 different products produced by Nepal Aushadhi Limited, which is the only one government-owned pharmaceutical company. Now it's getting expanded to produce up to 35 in 2 years. So we are progressing like a, being around 2-3 different giants, and this country, market size is small country, is trying to expand. But there's big thing coming up with the expiry of our LDC and other, which we will touch base on that. But it's working towards on leveraging its own internal capacity. Now, as where Nepal sits on, even though I said Nepal is small in terms of market size, being an executive member in the WHO, Nepal is not quite that much small there. We have a executive capacity on the previous, current World Health Assembly was supposed to work on pandemic fund agreements, which is, there is a special, I think Article 8 or 12 roughly, which talks about PAPS, which is pathogen access and benefit sharing. So Nepal sits within the group of equity with 40 other countries, where there are certain things that we want to get approval of. Now it get extended to, you might want to add later on, it got extended to December 2026, where there's a special demand from the countries like Nepal that we sit in the table as a country that shares pathogens, and there are higher other countries that use the pathogen and make vaccines to cure the world philosophically. But it's more on a normative value. Okay, you produce the vaccines and medicine or diagnostic other and choose to help us later on. But where Nepal sits, along with many other countries, is if we are sharing pathogens to you, we want a share already declared to us. There's a 20% thing, 10% to give to the WHO, other 10% to the countries like Nepal and others. But not just limiting to that, Nepal and other countries are asking for more, not just giving the 10% share of vaccine or diagnostic other service, but more on capacity building, technology transfer, and non-exclusive licensing. So summarizing it all, each 3 tiers of government has its own right and exercising its independence, and position of the country itself, and its little power within the global space, trying to execute that for other lower income countries' context as well. And I would like to end, I will just add maybe 20 seconds. I'm not quite comfortable with the word global south and global north. I feel global south and global north, though it's been divided, I can proudly say I'm proud South Asian, but when I am getting considered as someone from global south, I just feel small. So I would like, it's a question I'm sending to the audience here. Let's try to find how this term has been coined. I don't think it's a word decided by lower income country or countries like us to say, let's allocate or let's give us an identity as an entire global south. The history is different. I want you, all of you, to go dig into and look into it. Why don't we redefine our definition and identity by ourselves as a proud South Asian? And then I would like to add my sayings here. Thank you.
Prakriti, with the permission of Dr. Abekon and Dr. Shukla as well, I'd like to start this next sort of round of questions with you very quickly. We know that trade agreements across the region are increasingly carrying TRIPS plus provisions that are narrowing the policy space that you were talking about. So how worried should the audience be? Who is watching these negotiations? Yeah, maybe, or Prakriti, and Dr. Palita as well, if you want to chime in. Yeah? So we know that trade agreements around the region are carrying TRIPS plus provisions. And this is, do you feel that, maybe you would disagree, do you feel that this is narrowing the policy space that we were discussing? And how worried should we be, and who is watching trade negotiations?
I think especially in context of Nepal, if we compare, we're given this, and there's a Doha declaration to allow a bit leverage on a public health production and everything. But as I mentioned, as you said, a small market Nepal, we're not getting that leverage to exercise things we could get being a part of lower LDCs and working on it. So a little on what the TRIPS plus pressures is likely to be for us is patents beyond 20 years. Now the leverage we get being within the range is so we can have up 20 years of patents, and then other pharmaceuticals can get in, but it asks to leverage beyond that. Another on restrictions on compulsory licensing and enforced data exclusivity. So oversight is thin and uneven. So civil society tracks TRIPS plus CRE, but small state trade delegations really, I realized that when I was given this question, I started looking into it more in details. I asked this to a few other stakeholders within my system, and they were like, yeah, let's look into it. So we're not that much prepared, mean that public health legal expertise in the room is very small than compared it should be. That's why Nepal participated on Group of 77 in China with 2023 Havana Declaration, which says complete independence, and then it's against the monopoly of technology that's been used by several other countries. So to get away from this is we need to find the alternates such as being a part of GSP, European Union system, which required certain conditions to be a part of it and to get certain waiver being from the low-income countries is we need to rectify ILO Convention 81 and 87. As far as I know, 81 has already been rectified by Nepal, which states more labor rights, minimum wages, a clarity on that. And another one is Convention 87 that sets a freedom to the labor union to get independent from the government interventions, which I think I checked in, it's underway to get rectified by Nepal as well. And there's also a specific requirement by EU on Cartesian protocol, which means protocol on biosafety. There are certain standards. If we want to be a part of that network, we need to follow on. So a few of these things are underway, but again saying that as a small market, if we get into TRIPS plus areas, our shares would be, we will get lost only by the 4% of our experts, whereas the Bangladesh will suffer from more than 14%. So it's a good timing to get to know more about what are the detrimental things that's going to happen and how we stay prepared. Thank you.
Thank you. Dr. Palitha, on that subject as well, on access, we know that donor and multilateral agency funding and financing is contracting sharply, has been contracting for the past 2 years. Is the WHO that you knew still able to act in some form as a guarantor of access? Or is that role now falling to, as Prakriti sort of outlined, falling to regions and states to claim for themselves? Let me change the mic. Yeah.
Sorry. I don't know whether she answered because her mic was echoing and could not catch every word. Sorry about that. Maybe she answered, said what I had planned to say. But I'll say two other things which are related. One thing, of course, is even if we are able to exercise the compulsory licensing and parallel imports, etc., many of our countries can't handle that. Because the requirement is that you have to have the capacity to produce in your own country. And most of our countries, except India and Bangladesh, don't have that capacity. Don't have the capacity for a number of reasons. Finance is one, that we don't have the machinery and the factories. But also, we don't have a single national medicines regulatory authority in our region, which has reached what is called level 3, the level 3 or 4, which is necessary for it to be recognized by anyone, even in your neighbors, even to export to our countries. India has level 3 for some, like vaccines. Thailand has for vaccines. We are now struggling to get to level 2, and so are most other countries. So this, theoretically, it is a possibility, but in practice, we don't have the capacity. The way we produce, we have a number of limitations as of now. For example, finance is one, but finance is not the main thing. The regulatory authority, GMPs, that's one major issue. Second is we don't have a market enough, unlike India. We don't have a market enough which can sustain an industry by itself, which means we have to export. And to export, we need to have other conditions which we have to fulfill. So there are a number of possible. But in the last 3-4 years, 2-3 good things have happened in our region, not necessarily in South Asia, but outside. For example, ASEAN is moving very fast. They have set up this big organization, big means they are for vaccine and medicines production, where Thailand, Indonesia, and Vietnam are jointly working on what we are talking of. And their system is growing very fast. Unfortunately, SAARC, of which I think, I'm not political about, I don't know the politics of SAARC, but SAARC, what I read and hear is that SAARC has not been able to deliver in any area in a significant way. So I was thinking, I was talking to some people also, maybe, now this is not to exclude anyone, but nevertheless, we might also have to explore organizations like the BIMSTEC, which do not have that kind of political connotation in our region, which might be a way of going this way. And I have little hope here because Sri Lanka is coordinating the technology and the innovation arm of BIMSTEC. So I was talking to my colleagues in the government who said this is something that we should take up. But regionalization is number one. Strengthening the country itself is the second. The larger thing we have to go now. Here I remember what Prof. Sundararaman said in the morning. Our countries, or the so-called South countries, I don't know whether we are South because we are above North. We are north of the equator, but we are called South. And people say we are East of what, I don't know. So it's now who set the rules? And for medicines also, that's the same thing. I always like this saying where I say, we always have to follow the golden rule. The one who has the gold lays down the rules. So we have issues that we need to come to terms with. So the good example of what I just mentioned is that, there's a big discussion going on in Geneva with regard to the ratification or development of the pandemic accord. They're hoping that what is holding it up is the fact that the countries have not agreed on how to share the products. The South countries, as you say, will give the virus for research. They will give the the category,
the patients.
No, for clinical trials, but and the North countries, so-called North, when I say North, the richer countries will produce the vaccines. The current debate, and they cannot sort out, is how do you share the output, the countermeasures and the vaccines from this? In that, what is the formula? The debate is going on, and if you follow the debate, 20%, 10% free, 20%, 30%, just trying to get the problem here is that if you go to this discussion in Geneva, our countries are very badly represented. India is the one country which is there. Thailand is the other country which is well versed with this, so they are in a big way. In fact, a Thai guy whom all of you know is the current co-chair of the PEBS discussions. But they are not being able to sort it out, which is the same thing. Ultimately, they will produce vaccines. When I say they, the North, so-called North, and the medicines at the counter, and we'll have to buy it. So they will. Now that is something that collectively we might be able to do something. Secondly, we should develop the capacity, like Africa is trying to develop now, to use the virus and produce these countermeasures, at least in some measure, partially. Over time, maybe 15, 20 years' time, we might be able to become more self-reliant on the developing countries together. I don't know when. I hope so. I hope quickly.
If I may, Dr. Abekon, before coming to Dr. Shukla, if I quickly ask you related, we saw during COVID-19 also this sort of confrontation between regional solidarity, especially when supplies are scarce. So do you see, what did the pandemic actually teach this region, South Asia, that we may have actually institutionalized, and what is it that we have already forgotten? Because you spoke about, the representation that our nations have, that these states have in these discussions is poor comparatively. You spoke about the need for regionalization as well and the importance of that regional solidarity. Do you see any hope at all? Maybe a quick shot, any hope at all or have those lessons of the pandemic been forgotten?
I've been hoping for the last 8 years, so I can't even
Okay.
Some things are good. I think some things, there are many things which have got better, definitely. But what we saw in COVID, and we are going to see it again, I hope not, but it is very possible that we are going to have another pandemic. A lot of people say it's not whether, it's when, which means we are going to come across all these situations once again. Unfortunately, human beings have a tendency to forget quickly. Now, the nationalism that we saw during the COVID time, I don't think it's disappeared. I know it's going to not going to disappear soon. We are going to have same problems and we are going to scramble. And even within the countries, if you saw, we got segmented, no? Certain groups were able to get the countermeasures and the vaccines faster than the others. In that way, I must say Sri Lanka, which has been in a very, very egalitarian in this, Sri Lanka handled it pretty well compared to many countries I know, even in the region, where even the poorest, our distribution networks were not really up to date, but we got it up and running quickly. We didn't have super cold ways of delivering it, but we got it very quickly. And I was very happy the way Sri Lanka made a few mistakes, no doubt. But in terms of equity, I think we handled it pretty well. Whereas some other countries that you know, it was not that good.
Thank you. Dr. Shukla? Yeah. Dr. Shukla, on the subject of financialized health as well, I wanted to ask you, when, maybe through your experience from the People's Health Movement as well, you can talk to us, the financialized health model that you're talking about, building countervailing power against that, what would that actually require? Is this something that can be done by civil society alone or by states alone, only with the state?
Yeah, before going to that, I'd just like to make a small comment about generic medicines also. because I feel that there's a bit of a paradox in India. On one hand, we export generic medicines across the world, and which are considered to be relatively low cost. And on the other hand, within our own country, expenditures on medicines are quite high. 70% of out-of-pocket spending is on medicines within India. So this paradox is something which it may look paradoxical, but actually, if you go a little deeper, it is basically two fractions of capital pursuing different strategies in different markets. So in the global market, Indian drug manufacturers are disrupting monopolies. And in the Indian market, Indian corporate hospitals are building monopolies. And both with the purpose of extracting profit. Anyway,
Profit-driven supply is the main driver at the end of the day.
But profit-driven supply and basically maximizing profits in the global market, it's a high volume, low margin kind of market. So margins are low, but the volumes are high. Within India, in the hospital sector, it's a high margin and restricted market, again to maximize profit. So just two different strategies to maximize profit. But coming to your original...
In that context, how do you build countervailing power against such a financialized model?
So the point is that, well, to begin with an incident which you all may have heard about, just less than a month back, a huge number of young people in India gathered in the national capital. And it started with a small kind of a slogan. Our Supreme Court's Chief Justice said that these many unemployed young people, they are like cockroaches. So one person said, what if all the cockroaches came together? What if all the people who are oppressed, who are exploited, who are in different ways deprived, what if they all came together in each of our countries? That is actually the basis on which we need to think. So without going into the many details in that, but what I'd like to say is that the People's Health Movement is exactly trying to do this. And the People's Health Movement is a global network active in more than 70 countries across the world, basically building movements around right to healthcare, strengthening public health services, regulating private healthcare, ensuring access to affordable and rational medicines, working on the social determinants of health, and overall transformation of health systems in a pro-people direction. So to give us some examples of the kind of activities that can be done or are being done is monitoring and demanding improved delivery of public health services, especially primary health care at the ground level, which we are doing in many places, demanding regulation of the rates of services in the private hospitals, which may be astronomical and need to be brought under control, demanding access to affordable medicines, and also that all medicines should be under rational drug price control, and that should be rationally regulated. And then, of course, demanding higher budgets for public health. In many cases, like India spends a very low amount on public health as part of its budget, just about 1.4%. So in many cases, public health budgets need to be significantly upscaled if we want to support all these improvements. And people need to be at the center of health services, their planning, their implementation, their monitoring. Communities need to be made central, and therefore community-based monitoring, community social audits, and so many other mechanisms by which people can actually monitor. So I would just like to say that even in the audience today here, there are members from PHM, People's Health Movement Sri Lanka. Indra Chapa is there, Menu is there, several of our friends are there. You can get in touch with them in case you're not already in touch. And of course, we are now planning, just to conclude, we are now planning a global anti-privatization, anti-commercialization of healthcare campaign. Because across the world, you go to UK, you go to United States, there also it's a problem. You go to Latin America, you go to Africa, everywhere in South Asia, it is a problem. Privatization and commercialization of healthcare are a cross-cutting issue across the world, and now we need voices to stand up and say, they are the few, we are the many. And everybody who's getting affected by privatization and commercialization of healthcare should come together, including small hospitals, including individual practitioners, including charitable providers, and of course, including the wide cross-section of ordinary people. A huge such alliance is required to stop commercialization and privatization and ensure resurrection of public systems, where of course we would learn from Sri Lanka and Thailand and various other models, but also move ahead. And what is being pushed back now needs to be privatization has to be rolled back. I think People's Health Movement is trying to do that.
Thank you, Dr. Abe. I think you brought us full circle back to our keynote speech in the morning, where we were discussing the values that shape and determine public health. I know we're short on time, so I'd like to quickly open the floor for questions. We have our mic runners in position over here, the second.
I forgot to mention Dr. Manoj is the founder of PHM in Sri Lanka. Yeah.
We expect the state to be the regulator to improve access. But unfortunately, what we see in most of the places, particularly our part of the world, the regulator is being regulated by the industry and few deal makers. So this is an unfortunate situation. So how are we going to actually improve access through regulation? Thank you.
Who would like to take that question? Multilateral, civil society, or state?
Yeah, I would have the same question as well. Like, how do we redefine the access? To what extent it is accessible, affordable, and available? So before working into the government, I did a research on inequitable access to infertility care. And then during our finding on our paper, which we also got an award from Oxford University, I'm not bragging on myself, it's quite comfortable to be outside the government and doing the research and then pointing out back to the government. Through our data, I'm giving a small case study example to you and would try to add on. I don't think I can answer it all. On the infertility care inaccessibility, we found out that during that time in 2021, there were 34 services infertility care. Out of 34, 2 were not private. All 32 clinics and hospitals for infertility care were private, which you will know the pain. And out of 2, 1 is non-profit, 1 was run by non-profit, another through the government. And we found out that out of 34, 32 of them are in the capital city. So what does this mean? How much centralized how centralized it is for one specific infertility care? Then we started talking to the sitting MPs and then government people, and then as a young group of people, we were able to influence the government decision at that time to make infertility care more decentralized. And then there was a new budgetary announcement in 2022, roughly, where government decided to have infertility care all across all 7 provinces. Well, the story didn't end there. Our question was not just to have hospitals or services. Access means, do we have enough human resources? Can they communicate and translate the language to the people there? Is it affordable within the corners in the different places? Now working in the government, same infertility care issues, now it's getting in the table. Now, okay, I understand the problem a bit. And then we're trying to work more through the policy level, which we learned a simple decision, simple programs or implementation will not be sustainable until it gets in the act and the policy. The new government is now working towards making accessibility not just as a building, as an accessibility, but human resource, infrastructure, and also trained resources to keep on it rolling in the rural area more. And the more we talk about, again, getting connected with the access, I connect it more with basic healthcare. So we have a primary, secondary, tertiary healthcare system where basic healthcare system was supposed to be all funded by the government. And then a couple of weeks ago, I shared about one of the leader in Nepal, Jagdish Prasad Arya, he's very close friend. He's a health advisor to the Prime Minister, and he and I, we work very closely with, okay, what we do, what's our agenda? And then both of us are very, very keen on how do we strengthen the basic healthcare system. How do we make basic healthcare system more and more accessible and affordable? Then we started looking into data. Sadly, so many infrastructures and buildings that were supposed to be already there are not even there. Very sad to see it through the government angle. And then we started prioritizing on, okay, what do we need? Where's the budget? And then we actually did some of the lobbying within government, through the government, to redirect the budget on the basic healthcare services. Because what I believe, until and unless the basic healthcare service itself is not strengthened, it's very difficult to connect with the larger goal of secondary and tertiary care. And it gets connected again back to the financing, how affordable it is. I would talk with some of the stakeholders here in Sri Lanka about how's the healthcare system, how's it's funded, and then because I asked that is we're working on restructuring the entire national health insurance system, and the entire notion behind this is a social security fund. Entire notion behind this is to make those quartile third, quartile fourth population who are very poor, who are poor and ultra poor, to make it accessible and free and to some extent affordable. So it's a very open-ended questions where we're trying our best, and I would love to maybe hear more about India and Sri Lanka perspective on it. Thank you.
So thanks, Dr. Manoj. I couldn't see you because of the light. So there are 4 things which a government can do to improve access to medicines very concretely. Number 1, regulating the prices effectively and rationally so that the prices are affordable. Number 2, boosting public pharma production, which means public sector units actually step into pharma production, expand their production to the extent possible, and ensure that, at least core drugs. A lot of our medicines right now are imported from China, actually the bulk. The API is imported from China. So in India also we have moved in the reverse direction. But we need to boost public pharma production. PHM is right now carrying out a study on this to document the positive examples of public pharma production. Number 3 is to negotiate and navigate the patent laws, and through compulsory licensing and other mechanisms to promote domestic production of lower cost medicines to the maximum extent possible, and instead of high cost, and there are many examples of that. And the 4th is bulk procurement by the public health system and making medicines available free of cost in the public health services across the country. So that from the primary health care center up to the district hospital, at least all basic medicines are available free of cost to people. So these are at least 4 things which governments can very concretely do to greatly expand the access to essential medicines.
Thank you, Dr. Shukla. Dr. Palita, you'd like to add to that?
Professor Manoj, you asked the question, is probably one of the best people in the room to answer the question. Because he was heading the only bulk buying, because Sri Lanka, the corporation or the government corporation that he was heading till recently, is the sole provider or purchaser of medicines to the government sector in Sri Lanka, not the private sector. So he knows the issues that come up every day, trying to do that. Yeah. What you said, I agree with everything that you said. It's not easy, but if you want a prescription, we can give a prescription. But preparing the formula, putting it together is the difficulty. We don't have all the APIs in one place.
Okay, I think maybe we can take another question if we have. Yes, over here. Can we get the microphone here, please?
Thank you, Najim, and it's an interesting session. I really appreciate it. So when you come to Sri Lanka, Dr. Palita, so it's a big crisis on power sharing. So when you come to the power sharing mechanism, we always in a mindset with the civil war syndrome of hegemony, the police and the land power. So it's a ground reality from myself, from the hill country as a civil society activist. It's a big challenge when you're talking about the pandemic monitoring, and it's also Dr. Abe. So this is the time, it's about the time to share the power because the government, the present government, come up with the policies with new systems and introducing after the youngsters came to all face and these systems has to be changed. It has to be people-centered healthcare. When you come to Sri Lankan reality, we have a central system. That means central government is handling all the national hospitals. When you come to the ground reality, when the provincial council, there is a rural hospital, and there is another hospital for the minority community. They call plantation estate hospitals, estate medical assistance. Why should we make it like that? So because the healthcare is every human is entitled for sovereignty and access. And this platform, if we can turn into a policy dialogue in Sri Lanka, already Najim knows how the hill country hospitals when the Ditwa period, when you visited. So this is the reality, Dr. Palitha will have to come to a national policy. Health for all. And also we'll have to include to the constitutional affairs, right to life. Still it's not in our mandatory with the constitution. Right to life, we'll have to include. Then only we can go for accessible, available and affordable rights for health. So this platform, I was really interested in this discussion and we can move further for a constitutional change and such kind of a power decentralizing in Sri Lanka beyond the mindset of the war hegemony, like sharing power, police power and land power. That is the topics we were talking in the South. Now it is the time to reform. Thank you. Thank you.
Dr. Palitha, do you agree that there is a two-tier public health system as Mr. Nitesh claims?
What he said is right.
Sorry.
What he said is right. I don't know anything beyond that about power sharing. I mean, I'm not very good. I have no power. I have nothing to share. But with regard to the health system, you're right. We have a central system where the so-called central government manages the so-called teaching hospitals and the large hospitals. And the provincial, we have a provincial council system which manages the other hospitals below. Same with education, in the same similar system. Now, this is a kind of historical development that we have inherited. But what you said, I mean, to me, seems to make sense. So you should advise us as to not me, the people who can make the decision. Yeah, I think basically I agree with you.
Yeah. Yes, Dr. Shukla. Last thoughts.
I'm not from Sri Lanka, but I'd just like to add to this. Decentralization of power is a critical component to improving public health services. And in Kerala, a neighboring state of not very far from you, you may be aware that where panchayats have been actually devolved 40% of the developmental funds so that local bodies can manage local public health facilities to a large extent and also plan in a decentralized and differentiated manner. So decentralization of power definitely can be one component of an entire, what you are calling power sharing. But I'd also like to add, power is never voluntarily shared. Power has to be claimed. So it has to be taken. And of course, if there is a movement, if there's a social upheaval, so power cannot just be, you write a formula and it starts getting shared. It never happens like that. Power has to be claimed by organized social forces, by civil society, by social movements. And in the health sector, we need more such movements. So you had the big Aragalaya, you had a huge upheaval of a certain kind, and it did lead to some change in the regime, definitely. But now in the health sector also, perhaps we need more such movements. And this is finally a suggestion for MSF. Can we put together all the positive examples from different South Asian countries? Let's take the constitution from Nepal, the public health system from Sri Lanka, the generic medicine production from India, and maybe something else, positive from Bangladesh, and put these together as examples that, look, these are the positive ways in which, health systems can be configured in a positive way. And suppose all of us had all of these, it would be a huge step forward. So actually that is a task which collaboratively perhaps can be done at least at the level of ideas and imagination, that right to health, right to healthcare as a basic human right needs to be claimed across South Asian countries. And today we have the technology, we have the know-how, and we also have the social and political experience to now actually operationalize right to healthcare in every country of South Asia. I think that should be a realistic dream that we should start working towards.
Thank you, Dr. Shukla. And final words by Prakriti.
No, I want to quickly add, even though we claim power as a different stakeholder, power is never absolute. So there has to be multiple angles of exercising or asking or demanding for power. And then as you mentioned the philosophy of health for all, something I started realizing after a couple of months of working in the government side, it should be economic health for all. There has to be economic and financing, big word in front of everything, because what I realized that when I communicate with finance ministry things, they would assume this as, oh, okay, we need to allocate certain budget for health, as like a bit like a burden rather than, oh, it's an investment. When we flip the narrative of we're investing in health, it gets different, it sets different agenda versus, oh, we need to allocate certain budget. And I think, I don't know how much you agree, health is always political. Health is politics. In a national level, in a regional level, in international level. When we talk about a sovereign nation to have a better healthcare system, if we're not getting support or if the regional and geopolitical context is not sound enough to match it, we cannot do much. As we explained, we had a chat before. So I realized that working on a several interministerial level of coordination, there has to be a labor, trade, different things with the Ministry of Labor, Youth, different things going on with the Ministry of Finance, a lot of things with the, airport security and the global security context and so many things. And if we keep, as you said, if you keep citizens' health as a center and started narrating it as an investment, I think we would be getting a better world. That's something I keep on saying myself and to my colleague at the office, because one of my TOR is to strengthen the healthcare system in Nepal. Thank you.
Thank you, Prakriti, Dr. Palita, and Dr. Abed. This has been an illuminating panel. Thank you for sharing your expertise, your ideas, and your experience. I think we'll have some tokens of appreciation for you as well.
Yes, can we have Parthasarathi Rajendran again for this? So. Thank you to all our panelists and Nadeem and Parthasarathi Rajendran for being on stage. With that, we have come to the end. Yeah, sorry about that. We've come to the end of the formal agenda for the day, but we have two more items on the docket. One of the last ones being Friends of MSF. Friends of MSF is a global network of student-run university societies that engage with humanitarian action through awareness building, educational events, and collaboration. Successful chapters have been formed in the UK and Ireland, in the United States, in Canada, Southern Africa, and now, for the first time, in South Asia. Can you guys hear me? Okay. So today, we will mark the inaugural chapter of Friends of MSF South Asia. To formalize this, let me please ask two students from the University of Colombo to join me on stage, Sean Kure and Ashwini Chandrakumar. They will share a couple of words about what this move means.
Check one. Good evening, ladies and gentlemen. I'm Sean Kure, a first-year undergraduate at the University of Colombo. I'm here today with my friends and my colleagues, all students from the University of Colombo, from different years, different faculties, and varying experience levels in humanitarian work. Personally, I study international relations, and I can attest to the fact that humanitarianism, raising awareness, volunteering, and fundraising for victims of disasters and conflict is of growing importance in today's world, especially in countries like Sri Lanka and the region of South Asia as a whole. The field of humanitarian work requires knowledge from all disciplines. Whether you are a student in STEM, the humanities, or commerce, logistics, you have the chance to bring forth your expertise into this field and become the next generation of humanitarians to carry on the challenging yet invaluable work. I think I speak for all of our upcoming members when I say that we plan on doing exactly that, to build on the projects and work that has been done by MSF South Asia. Furthermore, to add Sri Lanka to the list of countries in which students are also involved in the highly impactful work of MSF, and to finally make the world a better place. I would now like to invite my colleague Ashwini to share a few thoughts about her experience working with MSF as a student of the University of Colombo. Thank you.
Thank you, Sean. It's truly a privilege to be here at the launch of the Friends of MSF chapter, a much needed initiative, especially in this time and age, where there's a dire need for humanitarian aid all around the world. I was involved with the MSF in two occasions. One is through the Center for Planetary Health at the Faculty of Medicine, University of Colombo, where I was a part of the climate, health, and roundtable organized by the MSF, where I spoke about the youth perspectives on climate change. And two was in the aftermath of Cyclone Ditwa, where my organization, which was the co-group for disaster relief, we worked closely with the Disaster Management Center at the Emergency Operations Center. And we had inputs from the professionals at MSF. And we responded to the emergency calls coming to the DMC. We helped to coordinate the relief efforts there, and we also helped to collect the dry rations for the affected communities. So I'm truly grateful for the experiences I had as a medical student with MSF, because it really gave me insight as to the work that MSF does at an international and at a national level, and how they do it really. So I think this kind of insight is really invaluable really, for an undergraduate who wants to do more for those who are in need and who aspires to be a part of a humanitarian organization. And really what I have realized is that there are so many students who want to help, who want to do their part or who want to get involved, but they really have no avenue to do so, or they don't know how exactly to be involved. And I think that's the gap that the Friends of MSF chapter is planning to bridge, because it'll give undergraduates the first-hand experience of involving in the activities of MSF. It will give them a platform to speak up and really an access to a global health network, which is essentially a launching pad for a career in global health. And the best part is, it's not just limited to medical students. It's because really any humanitarian crises, wars, disasters cannot be singularly managed by healthcare workers. It requires a multidisciplinary effort. So the Friends of MSF chapter truly embodies this sentiment, because we are trying to welcome students from all the faculties to be a part of it. So it really is the first of its kind in Sri Lanka, and I'm incredibly happy to be here at its inception. And I hope that the MSF, Friends of MSF chapter will grow into something truly impactful over the upcoming years. So thank you for having us.
Thank you, Sean and Ashwini. We have the prospective members of the first Friends of MSF chapter, student chapter in South Asia, who are with us in the hall today. I'd like to invite our Executive Director, Mr. Parthasathi Rajendran, the Dean of the University of Colombo Faculty of Medicine, Professor Pujitha Wickramasinghe, and also from the medical faculty, Dr. Santusha Fernando on stage to hand out some tokens, a Friends of MSF starter kit, if you will, for our upcoming University of Colombo chapter members.
Thank you everyone for joining us stage. We are almost at the end of the Health and Humanities Summit for 2026. We began this morning with an empty sculpture. If you look to your right now, it's almost full. We may need a little bit more of your help to finish this off. And in many ways, this is symbolic for the entire argument for the day. Systems matter, financing matters, governance matters. But none of it exists with other people choosing again and again to show up for one another. Across borders, across professions, across cultures, and across communities. Because ultimately, humans need humans. To every speaker that joined on stage, every moderator, every panelist, thank you so much for your participation. To the team at MSF South Asia that built this summit, thank you so much. Everyone watching on the live stream and everyone else in this room, thank you for being a part of this conversation. And with that being said, the final piece of the day is a spoken word by Prashani Silva, who is our public health officer. This is a message from MSF.
Thank you, Dilmine. I would like to share a few words on behalf of MSF. In the hardest of times, when people are suffering, our humanity refuses to stop at a border. And in the end, what remains are the choices we made to care for one another. For ours is a world growing heavier with uncertainty, a world where conflicts deepen, where suffering multiplies, where places meant for healing and those who heal become targets. And yet, there are those who refuse to surrender tomorrow. They stand beside communities whose courage refuses to let suffering define their future. For the future has never belonged to a single voice. It is built in conversation, built by questions, built by those brave enough to challenge themselves and humble enough to listen to others. It is built when we make room for voices that have too often been left outside. So let us continue to cross borders, not only those marked on maps, but those that divide us from one another. And let us build across nations and across generations, and let us envision a future shaped by solidarity, equity, and hope. For the future of humanitarianism is not something that simply arrives. It is shaped by the choices we make today and what we envision and build together. On behalf of Doctors Without Borders, MSF South Asia, I thank each and every one of you for joining us today for the Health and Humanities Summit 2026. Thank you.
Thank you everyone for staying with us throughout the day. We still need your help to complete the sand sculpture. I think it's almost done. And we'll have evening tea served in the Queen's Court Ballroom. Thank you again for joining us.